Okay, I think we're ready to get going. So thank you everyone for joining on the Zoom for all of the student and resident research presentations. Um, the format will be, as you know, 5-minute presentations for the first group of abstracts and then rapid fire um, virtual poster abstracts, which will be 2-minute presentations for the second group. We're going to start today with our first, which is one of our Mount Sinai medical students, Saru Asfa, presenting on a project that was mentored by Dr. Isabel Germano. So Saru, I'll give you the screen.
Thank you. Um, could you see my screen? Great. Okay. Good morning, everybody. Today I'll be presenting on access to brain tumor care in the New York metropolitan area. This was a decade-long cross-sectional study. In terms of disclosures, the study has been approved by the Mount Sinai IRB as well as the data administrators for SPARCS, New York Department of Health. And this project was supported by the grant funding by Total program. In terms of background, the impact of socioeconomic status on brain tumor care has been highlighted by our group as well as others. And the first public hospital in New York City opened its doors in 1736, way before the United States was established. And these hospitals have proliferated to 13 public hospitals in New York City that serve as sites of both neurosurgical care as well as resident training. And you can see in the picture some of these hospitals, Bellevue, Elmhurst, and Jacobi. In terms of the objectives, we wanted to evaluate access to brain tumor care in the New York City area by focusing on the interaction of patients' socioeconomic status with where care has been delivered, i.e. public versus private hospitals, and the total charge for brain tumor care, and if there is any disparities in the charge. In terms of our methods, the data was obtained from SPARCS, and the subjects were all brain tumor patients in the 5 New York City boroughs who received brain tumor treatment. All subjects underwent craniotomy. Patients were dichotomized as either public hospital care recipients or private hospital care recipients. And the census tract median household income was used to classify them into 4 income quartiles as a proxy to evaluate socioeconomic status. The dependent variables were admission to a public hospital and the total charge for the care received. The cohorts consisted of 21,556 patients who received care at 12 public hospitals and 50 private hospitals. Female patients made up 54% of the cohort, and the mean age was 58 years old. Most of our patients had a white racial background, followed by Black, Hispanic, and Asian. Multiracial and natives made less than 6%. In terms of in terms of insurance coverage, public insurance took the lion's share, with Medicaid and Medicare consisting of 16 and 37%, followed by the privately insured patients. When we ask the question, which factors are associated with public hospital admission, we see that across the time of the study, across the 10 years, there was a reduced odds of getting admitted to a public hospital, which means more patients are getting admitted to a private hospital. In terms of length of stay, patients with longer pre-op and post-op length of stay tended to receive their care in a public hospital setting. Patients of Asian, Black, Hispanic background had higher odds of getting brain tumor treatment at a public hospital as compared to white patients. As compared to privately insured individuals, patients on Medicaid had a very high odds, 7.04, as compared to those on Medicare. As well, they had higher odds as compared to privately insured patients. As compared to the wealthiest group, income quartile 4, all income quartiles had higher odds of receiving care in a public hospital. The total charge for brain tumor care has been increasing across the board, and we could see that both in public and private, there was increased total charge, but public hospitals tended to charge less than the private institutions. When we asked which factors predict a higher total charge in public hospitals, we see that both male gender, discharge year, ED admission, and increased length of stay all contributed to an increased total charge in public hospitals. We saw a similar result in the private hospital setting, but we also noticed that age was a negative predictor across the age based on decades. So a 50-year-old patient as compared to a 60-year-old patient, the 60-year-old patient ended up having a reduced total charge. And we're doing some post-hoc analysis on this. In terms of conclusion, there's significant burden on public hospitals to treat low SCS, Medicare, Medicaid patients. brain tumor care has become more expensive in the last decade, and different charges for the same service might underpin variation in the total charge observed. And we want to conclude that we would need to strive for strategies to optimize equitable healthcare access, and we need to advocate for fair reimbursement policy for brain tumor patients to prevent preferential treatment by the institution or the administrators. I would like to thank the Mount Sinai University Department, my mentor, Dr. Germano, and Dr. Louis Tomalin, as well as the dual degree program at the Icahn School of Medicine. Thank you.
Thank you, Zaru. Do we have any questions?
If there are no questions, I have a comment. This is an incredibly hard study, and I want to congratulate you, Zaru, for an outstanding work. And I know that many hours went into it to prepare the study, and you've done really superbly, not just with the analysis, but also with the coordination. And thanks to the rest of the team member.
Zaru, I was actually going to ask, you mentioned optimizing strategies to make treatment for brain tumor patients more equitable. What's one strategy that you could imagine implementing that might move towards that?
The first thing that comes to mind is making sure that we have increased access to social services so that patients ending up in a public hospital might get like a more wrapped around care as compared to those who are getting care in a private setting.
I think that's a great observation. It's not just about paying for the medications or infusions or scans. It's about sort of the whole picture of ensuring the patient's care is covered. Okay, well, with that, we'll move on. Thank you, Zaru. The next up is Dr. Alejandro Carrasquilla, who is one of our residents, also mentored by Dr. Germano. And just a reminder before you get started, the presentations are 5 minutes. You'll get a 30-second warning before the end of the 5 minutes. If you're not wrapping up. And all of these first group of 17 presentations are eligible for the awards at the end of Research Day, which we'll announce when all the presentations are over. So thanks, and go ahead, Alejandro.
Thank you so much, Dr. Morgenstern. And can everybody see my presentation in presentation mode? Just want to thank Dr. Richardson for his lecture this morning and the Department for Research Day. I'm going to talk about enhanced recovery after adult brain tumor surgery and our project, which included Zaru Babel-Asfal, who you just heard, as well as Dr. Germano and the tumor section task force. So we'll talk about our study, and there are no conflicts of interest to disclose. In terms of introduction, enhanced recovery after surgery is a concept which aims to form a multidisciplinary protocol to optimize patients' early postoperative outcomes, including length of stay, pain, cost, and discharge home. And the early literature in the ERAS field initially focused on cardiac and gastrointestinal surgeries. It then gained traction in a number of fields, including spine surgery, but it has lagged behind in cranial neurosurgery. In 2019, the first randomized control trial of ERAS for elective craniotomies revealed a significant reduction in hospital length of stay and faster postoperative recovery, and then subsequent studies demonstrated the feasibility of ERAS protocols and the benefits in terms of the length of stay, cost of care, and postoperative pain. Just prior to our study, the Tumor Task Force had come out with a meta-analysis of ERAS within tumor craniotomies up to the year 2020 and demonstrated benefits of implementing the protocol. However, it still pointed to the need to find which elements of the ERAS protocols actually benefited the patients, and therefore our study aimed to identify individual elements that would form a feasible protocol with evidence-based benefits. Therefore, we performed a systematic literature review from 2020 to 2023 to capture the most up-to-date literature on the topic, and initially gained 362 studies using the terms ERAS, enhanced recovery, fast track, early recovery, and craniotomy. And after eliminating studies, we reached a total of 16 studies that met our criteria discussing ERAS outcomes within brain tumor surgery. We then extracted data, including numerous outcomes, cohort size, study design, and then tallied the outcomes of these studies using a binary format of whether each individual element conferred benefit or not, and analyze this to try to identify individual elements that were included across studies showing benefit in either length of stay, pain, or cost. This is a chart showing some of the most common elements seen across studies. They're divided into the preoperative period, the intraoperative period, and the postoperative period. And within each of those phases of care, the interventions include different ways of patient education, patient health, or procedural methods. And we tallied whether studies included any of these factors and whether those studies ultimately showed an improvement in outcome. The results of our systematic review included a total of 2,296 patients from the studies involved came from 8 different countries. There were 5 different study types, 4 randomized control trials, 5 prospective, 4 retrospective, 2 quality improvement, and 1 pragmatic study. And ultimately, when we tallied the data, our analysis demonstrated first that in terms of hospital length of stay, this was the most commonly reported outcome shown in 15 of 16 studies. And because of our cohort and our sample size, we chose a p-value of 1 to capture any important elements that might confer benefit. We also looked at pain reduction and cost reduction, and ultimately, the elements that were most significant were in terms of decreasing length of stay, and those are the ones we used to ultimately form our proposed ERAS protocol.
It's time to wrap up, Alan.
And from those, preoperative nutrition, social assessment, intraoperative operating room extubation, local and regional anesthetic block, prophylactic antibiotics and anti-epileptic medications, and postoperative discharge instructions, opiate-sparing analgesia, and early mobility showed benefit and formed our proposed protocol. Therefore, this proposed protocol has the benefit to aid in improving early postoperative outcomes for brain tumor patients. And I want to just acknowledge Zerubbabel Asfal, who was an incredible driving force and earned a well-merited co-first authorship on the manuscript that was submitted for this project, as well as Dr. Romano, who first generated the idea and really shaped our project and led this all throughout. So thank you.
Thank you. Do we have any questions?
Peter, again, sorry.
Sorry, Isabel, do you want to go first?
No, go ahead.
Oh, thank you so much. Alejandro, thanks for sharing your work. My question was, we know from your systematic review and from various other surgical subspecialties that the ERAS protocols work. What in your mind are barriers for implementing the protocol that you're proposing?
Yeah, so actually literature within this field shows that the more elements that the ERAS protocol has, the more logistically difficult it is to implement, and therefore the less adherence there is institutionally. So although I was trying to go quickly, I'll share one of my slides, which essentially shows this early randomized control trial had, this is their ERAS protocol, and it's only actually part of it, and it's not shown in the paper, in the main text of the paper. It's only in the supplemental material, and it's lengthy, and this makes it difficult to really pinpoint what's beneficial and makes it difficult to implement.
Dr. Richardson, you got a question as well.
Well, thanks. I was just curious if you have a sense of the similarity between the way the protocol is applied in the different studies at different places. Is it the same thing, or how different is it?
It's fairly similar. And one of the limitations in this field is also that each intervention or as part of the ERAS protocol can be fairly broad. For example, preoperative surgical counseling or procedural counseling can be interpreted in a number of ways, and it can be very in-depth to not so much, depending on how it's interpreted institutionally. So each of the elements has room for interpretation, and that's another limitation of this whole field of work.
So if I may, a comment about what prompted this. As the chair of the tumor section, we realized that it's very difficult for brain tumor patients to all have the same protocol. And so our idea was to really try to streamline it, Nia, in answer to your question. If the protocol is too complex, if there are too many elements, there are too many barriers, too many costs to go into the equation. And as Dr. Mark Richardson just said, if there are too many elements and we don't know which one, and if they're not homogeneous, we cannot really implement it. And so this was exactly the purpose of the task force. And I would like to congratulate Alejandro for his leadership. And as a mentor, to me, it's very important that the research is done properly, but also it's very important that the people that work together have a certain etiquette. And I have to say that watching Alejandro and Zero working at this together was phenomenal, because with their busy schedules, they were complementary to each other, respectful to each other. And as a mentor, they really show to me that they will be excellent mentors in the future. Oh, and before I finish, sorry, I want to congratulate Peter Morgenstern for this amazing day, and also thank Sarah and Maggie and the team, including all the professors within the neurosurgery department that graded the abstracts. Thank you for this fantastic opportunity to share our research.
Thank you, Dr. Germano. We'll move on to Dr. Ray Feng, who's mentored by Dr. Dengayich.
Okay. Thank you, Dr. Morgenstern. Good morning, everyone. My name is Ray Feng. I'm the PGY6 resident, and I'm mentored by Dr. Dengayich. And today I'm going to present on our preliminary analysis of post-tracking of patient video data in the NSICU. So just to go over a little bit of background, to all of us, we know very well that the neurosurgical exam is the most crucial component in our assessment of our patients. We use it to track their progression, drive very important decision-making trajectories. For example, like when to take a patient for decompressive hemicraniectomy, when to shunt them for hydrocephalus. All of these critical decisions are based on our neurological exam of the patients. And it's also the key reason for people to be admitted to the NSICU. It's the only setting in the hospital where patients are monitored on a Q1-hour basis for neurochecks with specially neuro-trained nurses, providers, and neurocritical care trained attendings. But our ability to continuously and subjectively quantify this neurological exam is very limited. Even in the NSICU, this exam has limitations. We're only doing it at Q1-hour intervals. It can be very subjective. It might not pick up patients who have subtle and subacute changes, for example, over the course of 2 weeks, where there's different teams seeing the patient. So measuring this continuous neurological exam is an unmet need, but we do have data available. There's video data that comes from patients who've been putting on video EEG. There's many of those patients in NSICU. So that's where we got the idea from, which is to use Pose AI, a method that tracks movement and that has already been used in athletics to improve performance. And we hypothesized that this Pose AI algorithm can predict neurological changes in the NSICU. And our close collaborator has already demonstrated some success with this technology in the NICU population. So this is our workflow. We essentially gather the video data, we analyze it, use our Pose AI, and then we will generate a quantified data point to monitor their exam. This is a very preliminary study, which we used only a single patient. And this single patient had 2 episodes of being on video EEG, which you can see correlating to the red dots on this chart. And we randomly selected a 2-minute video clip from each of the episodes that the patient was on video EEG. And we correlated it as a proof of concept to the RASS scale, which is a sedation agitation scale that's documented by the neuro NSICU nurse on a Q1 hour basis. So this is our Pose algorithm, and you can see our labeling of the patients and their extremities. And we use the XGBoost classifier to predict the depth of sedation. So this is a video of the patient where they were less sedated. So in this diagram, you can see that the algorithm is able to track the patient moving their arm and also moving their leg. And this is a video coming from where the patient is more deeply sedated. And as you can see, there's a lot less variation in terms of the tracking. And this is just representing that data in graphic form, where the x-axis is on the left, the y-axis coordinate movement is on the right. As you can see, between the RASS -4 score and the RASS 0 score, there's much greater variability when the RASS is 0. So again, presenting our data in the graph form, we did find a statistically significant difference between the 2 video clips. So obviously we have a lot of limitation with this preliminary analysis. It's only on a single patient. It's a very short time interval. It's on a separate video episode. And also in general, to scale our study, there's a limitation in terms of camera source data and also patient tracking, especially in patients who are covered by bedding or restraints. And again, this probably also won't work very well in patients who are comatose or minimally conscious. But still, we are able to show that Pose tracking can differentiate light versus deep sedation in a patient in the NSICU. And we envision that this technology in the future can be used for continuous monitoring that provides data akin to the continuous cardiorespiratory telemetry that we pretty much take for granted. And also future directions, including tracking patients and correlating with other clinical parameters. For example, for patients who has EVD, to see if it correlates with the ICP readings, if it correlates with their PIN score, and also if it correlates with their NIH stroke scale. And this technology can also offer neurotelemetry in a diverse range of settings, not just the ICU, but also on the floor, rehabilitation centers, and even nursing homes. So thank you very much for paying attention, and I can take any questions.
Dr. Richardson?
Thanks. That was very interesting. Can you comment on the challenges of synchronizing the data, the video tracking? That's number 1. And number 2, have you tried this in your epilepsy monitoring unit?
The second question is easy to answer. No, we have not tried this in our epilepsy monitoring unit, but it certainly would be it certainly would be really interesting to track that set of patients. And go back to your first question, synchronizing the video data, just in terms of.
Yeah, synchronizing the body capture data with the other signals in the ICU, the video. Just I'm assuming you're synchronizing this to the vitals and everything else.
Yes, exactly. So right now for this preliminary study, we only use the RAS scale, which is documented at hourly kilowatt-hour basis, which is not great. Again, it's not continuous. We haven't synchronized it with the other continuous data, such as heart rate or respiratory rate. We haven't done that yet. That's in progress for us to figure out.
So we do have a Bedmaster recording at Mount Sinai. We end up dumping the Bedmaster recording after 3 months or so if it's not being used. So we have the potential of synchronizing this data. And like Ray said, that's going to be one of our next steps to see if we can marry the two data sets and look at what time synchronized events look like, and then interventions and what happens both to the video data and then to the other vitals data. But that's an obvious thing that absolutely needs to be solved. Thank you.
Mm-hmm.
Thank you.
Great job, Ray. Thank you so much for giving us the opportunity to present.
Next up, thank you. Next up, we have Dr. Cummins, mentored by Dr. Panoff.
Great. Thanks, Dr. Morgenstern. Can everyone see my slides okay?
Yes, we can.
Okay, so I'm going to be presenting on modulation of human hippocampal and amygdala electrophysiology with meditation. Mind wandering is a pervasive human brain state that occupies about 50% of waking consciousness, involves daydreaming into things that happened in the past to events that may happen in the future, and as you can imagine, may drive negative emotions such as stress and depression. Mindfulness meditation is an opposing brain state to mind wandering, in which thought is focused on a single stimuli, such as the breath. Both scalp EEG and functional neuroimaging have explored mind wandering and mindfulness in humans. And in particular, both low frequency theta and alpha modulations, as well as higher frequency gamma modulations on scalp EEG, as well as functional neuroimaging has implicated a predominant role of the mesial temporal structures, such as the hippocampus and amygdala. However, no one has yet married this by looking at intracranial electrophysiology between these brain states. So in patients undergoing stereo EEG in the hippocampus and amygdala, we had them undergo a trial of mindfulness meditation and mind wandering. We first were interested in looking at normal brain, which we defined as non-lesional on MRI, and after stereo EEG, who ultimately had no hippocampal or amygdala epileptiform activity. We also were interested in looking at, does epileptiform brain change with changes in brain state? And so we also looked at non-lesional on MRI with epileptiform activity, but we used non-epileptiform epochs to have an approximation of a normal time period. We confirmed localization in the hippocampal and amygdala gray matter using Yale Brain Atlas. And then in order to actually analyze the squiggle of data, of time series data that we get from stereo EEG, we have to transform that data into the frequency domain. And then using a modeling technique called fitting 1/f, or FOOF processing, common in neural dynamics, we isolated the oscillatory activity in different frequency bands, including theta, alpha, beta, and gamma, and compared the power between mind wandering and mindfulness meditation. And then, as I said, looked at normal and epileptiform brain. Here are our contact localizations. We had 45 non-epileptiform contacts in quote-unquote normal brain and 20 in epileptiform brain. And I'm showing in blue is the hippocampus and red amygdala in normalized brain space. So here is the first result that we saw, which was essentially looking at the number of active contacts in the mesial temporal lobe across frequency bands. So in theta, alpha, beta, and gamma, this is for epileptiform and non-epileptiform or normal. And we saw the only significant result as far as active contact, the number of active contacts, was a significant increase. In the left here is mindfulness meditation versus on the right, mind wandering. We see a significant increase in the number of active contacts with mind wandering. And that was only true of non-epileptiform or normal brain, but not epileptiform. We also saw this when looking at the degree of activation. So looking at only active contacts, what is the peak power in each frequency band? And we again saw, unique to non-epileptiform or normal brain, there is a significant increase from meditation to mind wandering, both in beta and in gamma frequencies. We were also interested in, does this effect happen over time? So in patients implanted with the RNS, which we heard about earlier, we looked at the effect of meditation. And in this study, we looked at a slightly different form of meditation, which is called loving kindness or compassion meditation. As you can imagine, very memory-heavy circuitry and emotionally salient. And we actually saw the opposite finding, which was an increase in gamma activity with loving-kindness meditation compared to at baseline. And so a couple of interesting points here. Number one is the form of meditation may matter, but perhaps more interestingly, we saw that perhaps with neuromodulation, there is a shift as this brain is neuromodulated from epileptiform to non-epileptiform. And these brain regions that were once non-functional, at least with what we saw with stereo EEG, are re-engaged as functional as they are neuromodulated. So we saw that non-epileptiform brain electrophysiology is modulated uniquely by meditation. Epileptiform brain, based on the stereo EEG work, did not appear to be modulated by brain state. But really interestingly, with the RNS work, we think that possibly long-term neuromodulation may re-engage these once epileptiform, non-epileptiform brain networks into functional networks. And I have an example schematic of that here. You can see a patient implanted with RNS, leading to synaptic neuroplasticity and thus re-engagement of once epileptiform hippocampus into functional brain networks. So I want to thank Dr. Saez. Ignacio Saez is the main scientific mentor for this work, expert in electrophysiology. Dr. Panov, we probably heard about earlier, one of my neurosurgery mentors, and then Dr. Gatan, who also does stereo EEG, obviously, and helped implant many of these patients. So thanks to everyone in the department for supporting this work, and that's all I have.
Thank you, Dan. Do we have any questions? Dr. Richardson?
I have a question again. Yeah. Well, this is really interesting, this idea that you might have changed the underlying network with stimulation. But I'm curious about two things. Do you have patients that were implanted with SEEG and got RNS? So you have data in the same patient. That's number one. And number two, for the intracranial results from the EMU, is it just a few patients that explain that data, or are you seeing that effect across a lot of the patients in this cohort?
Yeah, so great question. And I didn't have, so the answer to the first question is unfortunately no. So all of the stereo EEG patients, none of them got RNS. So, this is kind of, when you are enrolling people, et cetera, unfortunately, we didn't get any of the same patients with RNS, with stereo EEG recordings as we got with RNS. So obviously, hopefully, prospectively, potentially, we will be able to do that. And as to the second question, can you repeat the second question? I want to make sure I understood you correctly. Sorry, Dr. Richardson.
I'm just curious if this gamma effect, that you saw, you're seeing it really across patients, or is it just a few of the patients explain the data? But I guess these plots are helping with this a little bit. How many patients?
Yeah, so this was in 8 patients. I didn't show the spectrograms or time frequency analysis, but if you look at the spectrograms in each individual patient, we actually do see this in every single patient. So that may have been an even more compelling piece of data. You can see from meditation to mind wandering, you see this shift in each individual patient, in the time frequency representation. So this was in 8 patients, and then the initial RNS work was in 9 patients, which were different patients. Yeah.
Thank you, Dan. Yeah, just, it's a pilot study. It's a small group, and it was done simultaneously. So Mark, for sure, we're going to try to get those stereo EEG patients, if they get an RNS, into the study and see how it compares. But the wonderful findings is that the type of meditation may definitely affect the brain differently and may train the networks differently. And it does seem like we have more activation with a very constructive type of meditation, which is loving kindness. And we have a real quieting of the network potentially with focused attention. So a lot of paths into the future. Thank you, Dan.
Thanks.
Thank you very much. We'll move on to Mert Karabacek, who is mentored by Dr. Margettis.
Good morning, everyone. My name is Mert Karabacek. I'm a research coordinator in our department and an upcoming PRF for the next academic year. So today I have the pleasure to present you our research on radiomics-based machine learning approach for non-invasive characterization of gliomas. So what is radiomics? Radiomics is a quantitative approach to medical imaging that quantifies images through mathematical extraction of spatial distribution, pixel interrelationships, and textual information. Building upon radiomics, radiogenomics focuses on the relationship between genomics and imaging phenotypes, bridging molecular biology and medical imaging. One of the main applications of radiogenomics is the non-invasive characterization of molecular subtypes and genomic mutations in tumors. This application is particularly relevant given the recent developments in the 2021 WHO-CNS tumor classification, which has incorporated further molecular data building upon the 2016 edition. This has significant therapeutic implications for glioblastomas and other glial tumors. Motivated by these developments, our study aimed to develop radiomics-based machine learning models for predicting tumor-grade histology and various molecular markers, including IDH mutation, 1p19q co-deletion, and MGMT promoter status. To achieve this, we followed the radiomics framework, which involves obtaining medical images, segmenting regions of interest, extracting and selecting features, developing predictive models, and deploying these models. While previous studies have confirmed the predictive capabilities of radiomics-based models, most of these studies remain as feasibility studies as they often fail to provide advancements in potential clinical adoption. So our second objective was to propose a framework for a user-friendly web application deploying the developed models. Now let's take a look at our methodology, starting with data acquisition. We use the Cancer Imaging Archive, TCIA, which hosts an archive of de-identified medical images of cancer patients. Specifically, we use TCGA GBM and TCGA LGG collections, which provide images matched to patients' genomic and histopathological data from the Cancer Genome Atlas, TCGA. However, since these collections were released before the WHO-CNS5, we needed to reclassify the cases. To do this, we obtained our histopathological and genomic data from a recent publication in which the authors reclassified available TCGA glioma cases according to the WHO-CNS5. For different outcomes, we had between 103 and 235 patients based on data availability. After preprocessing, we segmented tumor lesions as regions of interest. We use a pre-trained SWIN transformer model for fully automatic masking of tumor subregions. These subregions were used to extract radiomic features. We utilized PyRadiomics Python package for feature extraction. Over 14,000 features were extracted from each patient's MRI studies, and this process took us from images to quantitative features. To avoid overfitting, we had to decrease the number of extracted features. Lasso regression was used for feature selection, retaining only the most predictive features. This decreased the number of features from over 14,000 to between 49 and 87 for each outcome. For model development, we utilized a novel transformer-based algorithm named TAP-PFN. We evaluated our models with a 10-repeat 5-fold cross-validation. 5-fold cross-validation involves splitting the data into 5 equal parts, using 4 parts for training and 1 for testing, and repeating this 5 times. And 10 repeats means that this process was repeated 10 times with different folds for a more robust evaluation. The developed models showed almost excellent discriminatory abilities with AUC values around 0.90 for tumor grade and histology, and for molecular markers as well. The models demonstrated also good calibration, as shown by the neatly aligned calibration curves. Upon performance evaluation, we deployed our models in a web application framework for individualized predictions based on MRI studies. Here's our proposed web application in action. We start by uploading DICOM folders for T1 with contrast, T1 and T2 and FLAIR sequences. After the images are uploaded, the segmentation is done in the background with just a single click. And after segmentation, radiomic features are also extracted, selected, and made available to the user with a single click. Finally, you can get predictions for a single patient for a grade, histology, and molecular markers. In conclusion, these models have shown promise for non-invasive prediction of histopathological and molecular profiles of diffuse gliomas. And our study's one of the main contributions is that creating a user-friendly web application framework to facilitate the integration of radiomics-based machine learning models potentially into clinical practice. I'd like to thank Karina, an MD PhD student at Sinai, and Dr. Margueres for their support in this project, and you for your attention.
Thank you, Mert. Do we have any questions? Trevor?
Hey, Mert, this is awesome work. I really, really enjoyed this. And congratulations on continuing to do all the omics work that you're doing. The question I have was when you develop the model, you have the web-based application where you're able to put in and get estimations of the likelihood of different markers and histopathological features. Have you been able to look at any of the patients that we have here at Sinai so far and worked with the department to see if those are matching up yet and kind of get some prospective assessment?
Yeah, we haven't tried with our Sinai patients or like any other external validation data set. That's our like next plans in the analysis steps. But like we would definitely be interested in like first externally validating with another data set. But it is hard to find a data set has both these extensive genomic features and MRI studies. So we'll have to find a data set that has both in common for external validation. That's been challenging so far. But after that step, like we will definitely be interested in some kind of prospective work.
Thank you, Mert. Next up, we have Dr. Hartigan presenting a project mentored by Dr. Manco.
Great. Hi, thank you everybody for giving me the opportunity to speak on our work on spinal catheter thrombolytic administration and its outcomes in aneurysmal subarachnoid hemorrhage. It's a case series and meta-analysis, no disclosures. Thrombolytic therapy in aneurysmal subarachnoid hemorrhage has been suggested to improve outcomes, namely the rates of vasospasm as well as chronic hydrocephalus in multiple studies. In addition, there are other studies that have looked at lumbar drainage specifically in comparison to external ventricular drainage and how that may impact rates of those outcomes in aneurysmal subarachnoid hemorrhage as well. The Japanese group with Hamada developed a protocol called Itsuki that was looking at urokinase specifically administered through lumbar drains and even developed a kit to explore outcomes related to that and see if it improved the parameters in aneurysmal subarachnoid hemorrhage patients. We hypothesized that TPA administration through a lumbar drain in aneurysmal subarachnoid hemorrhage would be both safe and efficacious in reducing vasospasm and shunt dependency. Interestingly, a very nice meta-analysis by Michael Lawton's group out of Barrow recently showed that lumbar drainage specifically without any thrombolytic therapy was important in reducing or had a significant decrease in the overall morbidity associated with aneurysmal subarachnoid hemorrhage in comparison to EVDs noted here, with post-op MRS being improved. Interestingly, clinical vasospasm and shunt-dependent hydrocephalus were not impacted in lumbar drainage compared to EVD. So in our inclusion criteria, it's pretty standard. The most important thing I think that we would address in terms of the questions if we're doing lumbar drainage and aneurysmal subarachnoid hemorrhage was that we necessitated having an open third and fourth ventricle without casted vents, just to make sure that there was no risk for a herniation event. Everything else was relatively standard for most of our clinical trials. The lumbar drain was placed and we delivered a dose of 4 milligrams per day of TPA, 2 milligrams BID for up to 5 days with sequential imaging, and then assessed for the rates of vasospasm and other downstream markers. These are our results from our case series. We had 26 patients. The patients had the demographics seen here. Interestingly, we had no patients out of those 26 that ended up progressing towards shunt dependency. Symptomatic vasospasm was only present in one patient, which subsequently resolved with triple therapy. And the average subarach clearance on CT noted here is approximately 5 days. We had an average MRS at discharge of 1.8 and follow-up of 1.1. Here's just some representative pictures and some modified Fisher 3 patients before and after. You can see very thick cisternal subarachnoid blood after 5 days, and after 3 days, we had excellent clearance using this protocol in the degree of cisternal blood following coiling. So we next wanted to see whether or not there was data in the literature that would help support some of the findings we were seeing from our own case series. We performed a meta-analysis, which ultimately, through this scene here, we included 25 studies in the meta-analysis, examining patients that had lumbar drain and thrombolytic therapy or lumbar drainage alone So this is an expansion and on the previous meta-analysis, really from the one that Dr. Lawton's group had done. You can see that in symptomatic vasospasm, using a one-arm proportion model, that we had about a 10.8% proportion in the lumbar drain and thrombolytic of symptomatic vasospasm, compared to about 27%, which is very similar to what Dr. Lawton's group had seen in their study, indicating a significant improvement in rates of symptomatic vasospasm using lumbar drain and thrombolytics. Rates of hydrocephalus requiring shunt dependency were trending towards improvement in our meta-analysis, with a 8.2% versus 14%. However, the confidence intervals did slightly overlap and therefore not quite significant, despite an overall trend towards improvement. There was no difference in mortality between lumbar drain thrombolytics versus lumbar drainage alone. And overall, there were good rates of outcomes of around 70 to 80%, which is defined as an MRS at 0 to 2. So in conclusion, what we're able to show with this is that TPA administered through a lumbar drain is safe in aneurysmal subarachnoid hemorrhage when performed according to certain parameters. The meta-analysis helps to suggest that the use of thrombolytic therapy in lumbar drainage is effective at reducing clinical vasospasm compared to lumbar drain alone, which also was, as we know from the other meta-analysis, also shown to likely have benefit compared to EVD alone. So the results from this support the development of a large-scale clinical trial, which Dr. Mako and my mentor from Georgia, Dr. Howington, we're working towards trying to get that up and running and apply for some funding for that. So I'd be happy to take any questions related to our findings or the data.
Thank you. Do we have any questions?
I have a question. Nice paper, Trevor. I was going to ask you how this differs from Japanese experience published 10, 20 years ago. I thought definitively showing that lumbar TPA was pretty effective. Maybe the difference here is that most of these cases are coiled cases as opposed to clipped.
Yeah,
that
absolutely.
was one thing. And then the other thing was, did I understand you to say you excluded patients whose ventricles were passed with blood? Because that's a big indicator of poor outcomes. So are you pre-selecting patients who are destined to a better outcome by excluding those?
So that's a very good question in regards to just the criteria for inclusion. Majority of the studies that we had, we did include intraventricular blood. That was not an exclusion criteria for us. However, if they were completely casted such that there was high concern on the provider estimation of a degree for herniation, that was an exclusion criteria. But we did have modified fissure for patients included in the study, which we felt did address some of that, Dr. Betterson. The question regarding the Japanese data, so certainly a lot of the work had been done with local delivery of thrombolytics. They also had lumbar drainage, as I mentioned, in the Itsuki trials, that did demonstrate efficacy. However, while it was shown, it still, I think the point of this in terms of trying to do a larger scale clinical trial and look at the effects, they did use urokinase, which is obviously a different drug than TPA, but we wanted to show that the current paradigm where we are very EVD centric is perhaps maybe not always the best in patients with aneurysmal subarachnoid hemorrhage. It's certainly efficacious and it works, but given the results of lumbar drainage alone, which is starting to become questioned more, especially with Dr. Lawton's work, trying to combine TPA with lumbar drainage because of some of that more preliminary and more pilot data from the Japanese groups earlier on, that there may be a benefit that is overlooked.
Thank you, Trevor. I think we're going to have to move on for time. Next up is Dr. Bhimani, mentored by Dr. Marguedes. And just a reminder to all presenters, please just remember to introduce yourself and your role in the department.
Thank you, everybody. Thank you, Dr. Morgenstern. Hi, my name is Abhiraj Bhimani. I'm one of the fifth-year residents here at Sinai, and my topic is regarding a machine learning approach that can be interpreted to predict survival outcomes in spinal and mostly sacropelvic chordomas. Brief overview on chordomas. As we know, they're low-grade malignant tumors that arise from the remnants of the notochord with an incidence of less than 0.1%, less than 0.1 per 100,000 people in the United States. And a majority of them are found in sacrum, followed by the skull base, and our study specifically focused on the sacral chordomas. They're thought to be slow-growing and low to intermediate grade sarcomas per some molecular markers. However, they are locally invasive and often very aggressive during presentation. And the literature has reported a general 5 and 10-year survival of 75 and 47% respectively. The aim of our studies can be reflected based on the prior studies, which majority of which focused on individual prognostic factors at a population level, and they fail to predict, accurately predict survival outcomes for an individual patient. And there have been studies using machine learning algorithm to predict these survival outcomes for chordomas. However, a lot of them don't have their source code available for public and are very difficult to reproduce or replicate. There have been studies using nomogram as a common with any cancer studies. However, they fail to capture the complex interactions within the data set. So our study used a National Cancer Database to aim to generate the best predictive machine learning algorithm for 5 and 10-year mortality prediction for sacropelvic chordomas. We ran 5 supervised machine learning algorithms to predict these results. And our performance was evaluated using the area under the receiver operating curve, which we will see in the upcoming slides. The best of these models was selected and was integrated into a web application. And to give a weight to each of the predictor outcomes, we ended up using Shapley values, which is the commonly used statistical analysis to individualize the weight of each of the factors based on the overall mortality or overall outcome. 1,206 patients with chordomas were studied for a 5-year outcome, and 800 patients had data available for a 10-year mortality outcome. The overall mortalities were 35% and 70% in the overall population within this data. And out of the 5 algorithms who used CADBoost algorithm created top-performing models with area under receiver operating curve greater than 0.8 for both 5 and 10-year mortality predictors. So this is one of the graphs that we can see with the CADBoost algorithm for the confusion matrices, which is showing false positive and false negative, as well as true positives and true negatives generated by this algorithm compared to the initial, the actual available data. This figure shows the receiver operating curves for all the algorithms that we're running. And as you can see, most of the algorithms have a pretty good predictability. However, the CADBoost algorithm range has a larger area under the operating curve, and therefore was selected. However, most of these algorithms did end up having similar level of accuracy and reproducibility. And I think the most important part was this, SHAP values that were generated within 5 and 10-year survival. And this is a unique part about the machine learning algorithm and using the analysis that age, surgery, and surgical margins were the most important predictor for 5-year mortality, as well as maximal tumor dimension. And there's a slight difference between the weight. However, the overall importance of these 4, these 3 to 4 factors remain the same between 5 and 10 year. And this really helps individualize for a specific patient their mortality outcome based on the available data. Some of the limitations are inherent to the coding limitations with the retrospective databases, which we cannot verify the information put into this database. Another limitation is that only overall survival was analyzed, and we did not have any information for progression-free survival, which is important in diseases like chordoma to see how long a patient has a progression-free survival. and how long before there's a recurrence based on the surgical margins versus full resection. This database also only captures all-cause mortality and not disease-specific mortalities, which is one of the limitations. So it's not possible to know if the patient died of the chordoma versus some other disease. There's also no volumetric measurement of the tumor size, and therefore, thank you. And
Do we have
model
any-
daughter maximum
Do we have any
dimension.
questions? Okay, so next up is Alex Devarajan, who's mentored me.
Hey everyone, thank you, Dr. Morgenstern. So my name is Alex Devarajan. I'm a fourth-year medical student here at Mount Sinai, and I'm here today to talk to you about our experience with the use of an endoscopic throat-ventriculostomy as adjunctive management of hydrocephalus in our cohort of patients with vena vaginal malformations. So as a brief overview, vena vaginal malformations are congenital AVMs from the choroidal circulation to the persistent median prosencephalic vena Markowski, which is the precursor to the vena vaginal. They have a wide variety of presentations, but in infants especially, they can present with macrocephaly, hydrocephalus, seizures, and developmental delays. We have first-line therapy for them as endovascular embolization, but if left untreated, they are very fatal. The mortality approaches about 76.7%. So hydrocephalus is seen very frequently in these patients, as high as 50% in some single center series. There is, of course, many different etiologies of hydrocephalus, but of course, unfortunately, all of these do in fact apply and often in conjunction for these patients. We can have obstructive hydrocephalus from compression or hemorrhage, communicating hydrocephalus from overwhelmed venous drainage leading to venous congestion and subcortical calcifications. And then in the worst cases, cortical atrophy with melting brain syndrome, as we call it, leading to hydrocephalus ex vacuo. So the best option for these patients is actually just continuing endovascular embolization. Normalizing the degree of shunting will secondarily improve a lot of these drainage performance issues that we see in the brain. But there is still some space for traditional neurosurgical interventions. When we have an emergent presentation of hydrocephalus, or if that maximal endovascular therapy is insufficient in the moment to reduce AV shunting, we can try and do some kind of intervention. But we often see that these patients are refractory to VPS placements. They have high risk of complications, infection, failure requiring revision. And then even our other options, EVDs or fontanelle taps, end up being more of a temporary solution, and the hydrocephalus remains refractory over time. So we have endoscopic throat-ventriculostomy, or ETV, as a potential option. It is an alternative pathway for normal drainage, and it may be safe and effective because we don't put hardware like a VP shunt. We also have more permanent diversion compared to your EVDs or fontanelle taps. There have been some case reports suggesting that it's safe, but there's actually only 4 cases ever reported in literature about whether or not this is effective. So there's very scarce evidence. And in some cases, we can even combine the ETV in most procedures with a choroid plexus cauterization, which gives a lot of neurosurgeons, for a good reason, pause, because they're frequently supplied by choroidal feeders. And so there's concern about whether we can even apply that technique as well. So just provide an example patient before I go into the results. We have here sagittal T2 and T1 weighted MRIs on day 1 of life. There's a demonstrating a prominent vena vaginal malformation, dilated MPV, and proximal straight sinus dilation. And we potentially have this malformation fed by multiple branches of the bilateral PCAs. So here is the angiogram after 1 embolization. You can see in these AP lateral views of the left vertebral artery, we have this partially treated VOGM, which is supplied by the right PCA through the choroidal arcade and a left posterior medial choroidal artery. So here, after that embolization, about 5 days afterward, we have non-contrast coronal and sagittal CTs that demonstrate triventricular hydrocephalus without enlargement of the 4th ventricle. So this is likely a presentation of acute obstructive hydrocephalus at the level of the aqueduct. The embolization mass can be seen. And so based on these findings, along with the clinical presentation, upward gaze palsy, lethargy, emesis, we brought this patient for an ETV. These are some images from a scope for one of these ETVs. As you can see, we get a nice view of the 3rd ventricle with some translucency. And then on the right, we have an endoscopic view of the clivus, pons, and basilar artery. So we have a confirmed perforation, in this case, of the membrane of Lilliquist. And lastly, on a 1-year follow-up after cure, this T2 weighted sagittal MRI shows a persistently obliterated vena vaginal malformation. We have some flow voids here, suggestive of the patent third ventriculostomy. And of course, there is some ventriculomegaly, but this is not associated with any symptoms or deficits. And so we can safely call this a cured VOGM. So we reviewed all of our patients who did receive an ETV, and we reviewed multiple different characteristics clinically, along with technical parameters, and calculated ETV success scores with 6-month success rates on follow-up. And we identified 9 patients, so we do have a very large case series here of patients who received ETVs at any point during their management. All of the patients had either a partially treated or a cured Van malformation, and many patients were in fact under 1 year of age. We do note that the majority of these patients are presenting with obstructive etiologies. As we know, continuing embolization is more effective in the non-obstructive. So these emergent obstructive presentations, we see a lot of use for the ETV.
30 seconds out.
We did not attempt placing VPS in any of these patients. We had more temporary management strategies and did CPC in 3 of them. And all of our identified perioperative complications are resolved prior to discharge. We had a 100% success rate in these patients. And all these patients on follow-up, in fact, had confirmed patency along with improved or complete relief of their symptoms. So now we have about 7 of these patients that are actually fully cured of their Van Galen. In retrospect, timely embolization is critical to address any developing disorders. Okay, thank you. Here we have CPCs for partially treated Van Galens that are challenging but viable. And overall, there's more recent trends towards aggressive embolization that we need to be careful of for embolic material compression. So the large series works great. Thank you, everyone.
Thank you, Alex. Do you have any questions? We'll move on to Ian Odland, who's mentored by Dr. Kilner.
Hi, my name is Ian Odland, and I'm a medical student. I'll be presenting in the real-world evaluation of the accuracy of the Viz.ai automated intracranial hemorrhage volume calculation tool. This project was completed under the mentorship of Dr. Kellner. 75,000 Americans experience an ICH event each year, resulting in a 25 to 52% mortality rate. The volume of intracerebral hemorrhage and the presence and volume of intraventricular hemorrhage extension are primary predictors of 30-day mortality and long-term functional outcome. Rapid, accurate estimation of intracranial hemorrhage volume is critical to guiding patient management, objectively evaluating hematoma expansion, determining clinical trial eligibility, and predicting long-term patient outcomes. This figure demonstrates the techniques for estimating intracerebral hemorrhage. MABC-2, shown to the left, estimates intracerebral hemorrhage volume as a biconcave pyramid by multiplying together the manual estimation of 3 diameters and dividing by 2. Semi-autonomous segmentation, shown centrally, consists of outlining hemorrhages of each ICH cross-section and estimating volume. In recent years, artificial intelligence, or AI, has been developed to automatically identify and estimate intracranial hemorrhage volume. ICH segmentation, performed by Viz.ai, an FDA-approved, commercially available mobile-delivered AI platform, is shown to the right. MABC-2 is the current clinical standard of care as it facilitates rapid ICH volume estimation. However, MABC-2 is prone to inter-observer variability, inaccurate in large and irregular hematomas, and unable to estimate intraventricular hemorrhage volume. Semi-autonomous segmentation is typically used in the clinical research setting as it provides more accurate estimations, yet it is time and labor intensive and requires access to a workstation. Our hypothesis was that Viz.ai will more accurately estimate intracerebral hemorrhage volume than MABC-2 compared to semi-autonomous segmentation, and more rapidly estimate intracerebral hemorrhage volume than semi-autonomous segmentation. We developed a study to compare all 3 hemorrhage estimation techniques. Semi-autonomous segmentation was performed by a medical student on 3D Slicer and adjudicated by a board-certified neurosurgeon. MABC-2 was measured on PACS by a board-certified neurosurgeon. Scans were pushed from PACS to the Viz.ai mobile infrastructure for analysis. Criteria for inclusion was any adult patient triaged to a large urban health system with an ICH volume greater than 10 milliliters within 72 hours since last known well. Exclusionary criteria were axial CT scans less than 2.5 millimeters thickness, insufficient image resolution, and non-square aspect ratio. 139 patients met criteria with an average age of 64 plus or minus 13.9 years and were 61.9% male. 48.9% of hemorrhages were lobar, 51.1% were deep hemorrhages, and 42.6% had intraventricular hemorrhage extension. The mean ICH volume for MABC-2, semi-autonomous segmentation, and Viz.ai were 51 plus or minus 32 milliliters, 48 plus or minus 27 milliliters, and 52 plus or minus 31 milliliters, respectively. Linear regression comparing semi-autonomous segmentation ICH volume to Viz.ai ICH volume and a graph to the left produced a line of best fit with a very strong correlation coefficient of 0.9861, whereas linear regression comparing semi-autonomous segmentation ICH volume to MABC over 2 ICH volume produced a line of best fit with a less strong correlation coefficient of 0.86. The average percent volume difference was 10% for AI compared to 17% for MABC-2. Linear regression comparing semi-autonomous segmentation intraventricular hemorrhage volume to Viz.ai intraventricular hemorrhage volume produced a line of best fit with a very strong correlation coefficient of 0.96. Viz.ai has a 94.6% sensitivity and 94% specificity of detecting intraventricular hemorrhage extension in the presence of intracerebral hemorrhage volume. Finally, the time to send scans from the PACS station to the volume being reported on the Viz.ai mobile app was 2.5 minutes, whereas semi-autonomous segmentation time was 8 minutes. This combination of speed and accuracy suggests artificial intelligence volumetric segmentation is a viable option for clinical decision-making and clinical trial study use. I want to call particular attention to the fact that ICH volume and IVH volume are key criteria for assessing the efficacy of minimally invasive evacuation of ICH in clinical trials. MISTI-3 included intracerebral hemorrhages with a volume greater than 30 milliliters and excluded ICH with IVH extension requiring treatment of IVH-related mass effects or shift due to trapped ventricles. ENRICH included intracerebral hemorrhage volumes less than 30 milliliters or greater than 30 milliliters and less than 80 milliliters, and excluded intraventricular hemorrhage extension estimated to be greater than 50% of either lateral ventricle. Finally, the study introduces accurate quantitative estimation of intraventricular hemorrhage volume in contrast to the semi-quantitative techniques, aka modified Greb score, used clinically today. Thank you.
Thank you, Ian. Do we have any questions? Just a comment for me. I think the applications of these AI tools are really, have been really impressive in speeding up clinical assessment. And I'm really interested in seeing how they develop and work into our clinical paradigm, because especially for time-sensitive diagnoses like stroke or ICH, it could be really valuable when you think of the weight that assessing those images sort of bears on a radiology department.
Yeah, it takes a long time to do these calculations in real time, and the accuracy, as you saw here, is not great when you do it yourself. And so this kind of rigorous analysis is exactly what's needed to make this the standard in the field. So great job, Ian.
Right, thank you. So we'll move on to Karina Shea, who's mentored by Dr. Margettis.
All right. Awesome. Hi, guys. I'm Karina Sia. I'm an MD PhD student here at Sinai, and I'm excited to share our work with you. So degenerative cervical myelopathy is a spinal cord condition characterized by spinal cord compression, pain, and neurological dysfunction. And these symptoms may correspond to the degree of stenosis, but symptoms can actually be quite variable. So identifying who is at risk of onset and progression of disease is really important for improving outcomes. So since cervical myelopathy is a degenerative disease, it has historically been attributed to just wear and tear, but studies have actually shown that family history explains the majority of the variability in disease incidence, even compared to age and occupational injury. So what are these underlying genetic factors that are conferring risk? Studies have attempted to analyze this using candidate gene approaches, which is really a hypothesis-driven approach. But the problem with this is that, these represent small hand-picked lists of genes, and these are usually really conducted in these small homogeneous populations. So as genomic sequencing costs have plummeted, we now have this ability to assess variants on this genome-wide scale in millions of people in these genome-wide association studies, or GWAS. But the problem with GWAS is it's shown that most GWAS variants actually fall within non-coding regions of the genome, which makes it really hard to decipher how these variants are actually conferring risks. So actually, these variants usually perform regulatory functions that lead to these quantitative changes in mRNA and protein, but often the variant that does so is not actually the nearest neighbor of that gene. So there's a lot of interest in how can we actually predict the impact of disorder-associated variants from GWAS on actual gene expression. And one way to do this is called transcriptomic imputation. So this takes genotype information for each individual and uses this to predict gene expression. And then it takes this gene expression information and we can use this to assess, which genes are associated with which traits, such as cervical myelopathy compared to controls. So here, what we did was we used the Mount Sinai BioMe Biobank, which it has genotypes for over 30,000 individuals matched to electronic health records. And then using transcriptomic imputation models, we can predict the gene expression profiles for each individual in a ton of different tissues. So using this, can we identify genes that confer predisposition to cervical myelopathy? Well, so the Biobank has 558 individuals with cervical myelopathy and about 31,000 controls. This cohort's relatively age, sex, and race matched. And we performed transcriptomic imputation using pre-trained models for the spinal cord, skeletal muscle, cultured fibroblasts, tibial nerve, which we use as peripheral nerve, and whole blood. And so for the sake of time, I'm just going to show you results from 3 of the tissues. So in the spinal cord, we identified 3 genes associated with cervical myelopathy, which includes HES6. This is a gene involved in neuron glia balance, PI16, which is associated with mechanical nociception, and TTC12, which has been associated with neuropathic inflammatory pain. In peripheral nerves, we identified 8 genes associated with cervical myelopathy, including this KLH-L29 gene, which is involved in chemosensitivity, BDH2, which is and CLEC4D, which are associated with inflammation, and then USP43, which is associated with proliferation. And then finally, in whole blood, we identified the C1RL gene, which is a complement component that could potentially be a potential biomarker indicating this genetic susceptibility to cervical myelopathy. So then to translate these expression signatures into clinically actionable information, we next look to see if there are any known drugs that could potentially reverse the cervical myelopathy associated signature. So to do this, we used a database of known transcriptomic responses to drugs in what's called the CMAP database. And then we used our gene expression signatures that we had just found from transcriptomic imputation and asked, could we find drugs that reversed the signature? And so out of a database of over 1,300 compounds, we identified 22 that significantly inversely correlated with our expression signature. And just to highlight a few, this included things like anti-proliferative compounds, a GABA agonist, minoxidil, calcium channel blockers, cytochrome P450 inhibitors, as well as even sex hormones. And I have lots of hypotheses that we can go into if you have any questions. So in summary, we were able to identify genes associated with cervical myelopathy across different tissues, and these included proliferative genes, which may indicate a genetic predisposition to, some enhanced degree of stenosis, but then also inflammatory nociceptive genes, which may indicate some sort of increased sensitivity to even small amounts of stenosis. And in response to this, we identified anti-proliferative, vasodilatory, neuromodulatory drugs that may actually target these mechanisms that would be, good early candidates for preclinical studies. Obviously, there's limitations of the study, which are that, the expression information is imputed, which will inherently contain some error. And we would love to perform RNA sequencing from real tissues to identify how well the signature compares. Our case control definitions were also limited to ICD codes due to the biobank, which may not accurately reflect the true incidence of disease. And, there's also overlap with cases with lumbar pathologies. So our signature may not be specific to cervical pathology. And then, even though the Sinai Biobank is relatively large, 30,000 people, there are bigger biobanks out there. We'd love to replicate our findings in a cohort such as the UK Biobank, which has about 400,000 people. So with that, thank you to Dr. Margettis and Mert, who have been incredible mentors, and to the department. Thank you so much for welcoming me, and I'm happy to take any questions.
Thank you. Do we have any questions? Dan?
Hey, Karina, this is really interesting work. So you mentioned it's kind of limited by CPT or ICD codes. So do you think the genes that you identified are more identifying people that are symptomatic from cervical myelopathy? Because obviously most of these people don't have scans, like most of the controls. So only the people, getting a scan are symptomatic generally, right? So
yeah, absolutely. And I think that a better control actually would be asymptomatic stenosis, right? Because what we're seeing in terms of like a, proliferative predisposition or a predisposition to hypersensitivity, to me, is likely to lead to the specifically symptomatic cervical myelopathy. And so I would love to compare that in people with imaging to identify even, between individuals who just incidentally are found to have cervical stenosis without myelopathy. Absolutely.
Thank you. Next up is Varun Subramanian, who is mentored by Dr. Panov.
All right. So good morning, everybody. My name is Varun Subramanian. I'm a third-year medical student working with Doctors Ted Panov and Sadi Gatan. And today I'll be talking about thalamic connectivity for RNS and epilepsy and its use to improve surgical targeting. Now, after Dr. Richardson's talk this morning, much of the background is redundant, but very briefly, 30% of epilepsy is drug-resistant. Surgery is effective for seizure control, but not always possible. And in these patients, we can potentially use neuromodulation. Now, for closed-loop RNS, the thalamus has emerged as an important target, and this is because it serves as an access node to modulate large areas of the brain with relatively small electrodes. And specific nuclei which have been targeted with success include the ANT, CM, and pulvinar. Now, in the present study, we had 17 patients undergo stereotactic EEG and RNS in either of these nuclei. And in terms of seizure outcome, 11 of 17 patients were responders, meaning greater than 50% seizure reduction. And within this group, 5 actually had greater than 90% improvement, with 2 achieving seizure freedom. And on the other hand, we also had 6 patients who did not respond favorably. And this really highlights one of the predominant challenges of RNS, which was mentioned earlier, that being the mechanism behind successful therapeutic stimulation is largely unknown. Now, of course, this project isn't just an institutional experience of RNS, and with this context, we can get into the true objectives of our study. And the first part was to uncover the connectivity profiles of the thalamic nuclei. And this was done to answer a very simple question, which is, what exactly is being stimulated when we implant in these nuclei? And the simple question becomes really interesting when we consider that each nucleus is comprised of subnuclei. So let's take the pulvinar, for example, largest thalamic nucleus and a great representation, as seen here, of differential connectivity within subnuclei. Now, typical indication for pulvinar posterior quadrant epilepsy. And beginning with the pulvinar medial, we see many streamlines to the parieto-occipital cortex, but we also see connectivity with the temporal cortex. Pulvinar inferior shows a drastically different profile with very strong connectivity to temporal structures, but almost nothing to the posterior quadrant. And finally, the pulvinar anterior, almost entirely sensory motor. Now, the differential connectivity was true for the subnuclei and the ANT, showing different flavors of the Papez circuit. And it was also true for the intralaminar nuclei, centromedian, centrolateral, parafascicularis. So what does this tell us? Well, it's suggesting that we don't necessarily need a concept of nucleus-based targeting, but rather a concept of tract targeting. And this becomes important when realizing that connectivity with the cortex matters when targeting nuclei with neuromodulation, which we demonstrate through our second objective, which is to determine the networks associated with seizure control within our cohort. And we did this by first finding the volume of tissue activated, the VTA, by thalamic RNS electrodes. And we then determined the seizure onset zone per the SEEG data. And finally, we overlaid both to calculate the relative connectivity strength. So in other words, tracks containing the VTA, tracks containing the seizure onset zone, and seeing the overlap. And we wanted to determine whether connectivity strength was relevant to seizure response. And in fact, it is. So we actually found a strong correlation between connectivity strength and overlap of the VTA tracks and seizure onset zone tracks. And this can be seen pretty clearly with a couple of patients from our cohort. So this individual in the top right had seizure activity along the premotor, orbitofrontal, and mesial temporal cortices, and the colored fibers are tracks stimulated by RNS. Strong overlap, strong response. And contrast this to a patient with seizure onset in the right frontal area, but little involvement of that area with stimulation. So to conclude, we've shown that there's a greater level of specificity when it comes to connectivity within thalamic nuclei, that being thalamic subnuclei and the tracks therein. And using data from our patients, we've shown that not only is there an association between connectivity strength and seizure response, but there's actually a direct positive relationship. Now, of course, these results are preliminary and there's a lot more patients to analyze, but we do think that it opens up a new type of paradigm when thinking about neuromodulation. That's moving beyond, say, a purely anatomic proximity to nucleus-based approach, and more so towards a tract-focused, network-guided, and connectivity-based approach. Thank you all very much, and I'd like to express my gratitude to my mentors, Dr. Panov, Dr. Abasias Chassin at the University of Nebraska, and Dr. Gatan. Happy to answer any questions.
Thank you, Varun. Dr. Richardson?
Nice talk, Varun. I think you brought up a very important point that I didn't emphasize, in my talk earlier. For instance, when we targeted the CM, we realized in the first cohort of patients that we didn't do a very good job of hitting it because we had used old Schottenbrand Atlas coordinates, and that's why we call it CM region stimulation. So I think you hit the nail on the head that it's understanding the connectivity pathways, and we're still not sure exactly what's being stimulated. Thank you.
If I can, oh, please, Dan.
Just a quick question, Varun. So obviously, Dr. Coppell does most of the DBS procedures, and he really ingrains in us that it's the white matter, stimulation on the white matter that leads to efficacy, not targeting the gray matter nuclei. Do you think that that's the same or different in RNS? And do you think a tractography-based approach to targeting the leads is, as Dr. Coppell's moving toward with DBS? Do you think that this is what your work suggests, or what do you think the mechanism is? Do you think it's different for RNS versus DBS?
Well, so one, that's a great question. And, Dr. Coppell focuses on movement disorders, psychiatric disorders, and based on his workflow that we've both seen, I think that the tract-based targeting and tractography is immediately useful for the neurosurgical workflow. And there's been several studies published by, Dr. Coppell, his group, and also Dr. Avicias Chassin that show that it's actually a greater stimulation of the tracts, which is the vehicle for the therapeutic stimulation, that leads to an improved response. So for movement disorders, greater stimulation of the DRTT leads to better control of movement disorder symptoms. And it's also been shown in OCD with the, I believe, anterior limb of the internal capsule, and also in depression. So when thinking about, the future of this project, where it can go and how it can actually influence patient care, I think, yeah, this tract-based targeting, focusing on the white matter, which is actually the way that the stimulation gets transported, is going to be very useful.
Thank you, Varun. Next up, we have Pamela Jagtani, who is mentored by Dr. Margettis.
Hi, everyone. My name is Pamela Jagtiani. I'm a rising MS3 from SUNY Downstate, and I've had the pleasure of being mentored by Dr. Margettis over the last 2 years. Okay, so today I'm going to be discussing spinal cord tumors, namely intramedullary spinal cord tumors. So primary spinal cord tumors are relatively uncommon in children with an estimated incidence of 0.3 per 100,000 person per year. And these rare tumors make up less than 5% of all pediatric CNS tumors. So the objective of our study, so the study utilizes NCDB to investigate the largest cohort of surgically treated pediatric intramedullary spinal cord tumors to date. And while previous NCDB analysis have focused primarily on specific histologies like astrocytoma, ependymoma, or hemangioblastoma, a comprehensive analysis was lacking. So that's where our study came in. And the study aimed to characterize the socio-demographic factors, patterns of care, and survival outcomes. So our methods, our patient population included pediatric patients less than 21 years diagnosed with intramedullary spinal cord tumors who underwent surgical resection of their tumors between 2004 and 2018. And like I said earlier, they included, we compiled ependymoma, astrocytoma, and hemangioblastoma, and limited to the primary tumors located in the spinal cord and cauda equina. Variables, we analyzed demographic and socioeconomic variables such as age, sex, race, Hispanic ethnicity, insurance status, median household income, percentage of non-high school graduates, residing population size, and Charlson Diosphore. And age was characterized into 4 groups, 0 to 5 years, 6 to 10, 11 to 15, and 16 to 21. And tumor-specific variables included histology, tumor dimension, tumor grade, and then maximum tumor dimension was characterized into less than 5 centimeters and greater than 5 centimeters. And grade 1 and 2 were characterized as low grade, while grade 3 and 4 were characterized as high grade. And our outcomes of interest for overall survival and secondary outcomes include surgery, radiotherapy, chemotherapy, and then short-term postoperative outcomes like unplanned readmissions within 30 days and prolonged length of stay. So these are our results in heat maps. So the study included 420 patients, and the majority of the patients in our study were male, white, and non-Hispanics. And most patients had private insurance, and they resided in metropolitan areas with higher median incomes and lower percentages of non-high school graduates. And we found that patients residing in urban and rural areas where the population was less than 250,000 were more than 60% likely to receive radiotherapy compared to patients residing in metropolitan areas. And patients of Hispanic ethnicity and patients without insurance coverage and patients residing in zip codes with a higher percentage of non-high school graduates had higher mortality hazards. We found that the most common tumor histology was ependymoma, followed by astrocytoma and hemangioblastoma. And due to concerns about like long-term cognitive effects, our results agreed with the current data that radiation therapy is typically avoided in children under 4 years old. And aligning with this guidance, we also found that the highest radiotherapy utilization was in older children from 6 to 10 years. And similarly, chemotherapy is often used in younger patients to delay or avoid radiotherapy, and our findings suggested the same. Triple mode therapy was most commonly used in children's age 6 to 10, while surgery alone was the treatment for hemangioblastomas. And female patients actually had a lower likelihood of receiving chemotherapy compared to male patients, and patients with larger tumors and higher grade tumors were more likely to receive a combination of surgery, radiotherapy, and triple mode therapy. And patients with astrocytomas were more likely to receive chemotherapy, but less likely to receive radiotherapy. And these are Kaplan-Meier's survival estimates. And there was no statistical association that we found between overall survival and age categories, but tumor histology, maximum tumor dimension, and grade were significantly associated with overall survival. And in the multivariate Cox proportional hazards model that I will show on the next slide, we found that astrocytoma and higher grade tumors had significantly higher mortality hazards. And patients who received radiotherapy or chemotherapy had worse overall survival compared to those who didn't receive chemotherapy. And patients who received triple mode therapy also had worse overall survival. And these are the multivariate Cox proportional hazards models that assess the mortality risk. And then in conclusion, like I said, this was, we compiled all 3 types of intramedullary spinal cord tumors, and further research is needed to optimize risk-adapted treatment strategies. And just a thank you to Mert and Abhi and Dr. Morgenstern and Dr. Margettis and their mentorship, because without them, this study would not have been possible. Thank you.
Thank you, Pamela. Do you have any questions? Nice job. Okay, so we'll move on to Bahi Ezat, who is mentored by Dr. Hickman.
Thank you, Dr. Margettis. Hi, everyone. My name is Bahi, and as part of Dr. Hickman's research group, I'm presenting our study on traumatic brain outcomes, traumatic brain injury outcomes at the epicenter of the United States COVID-19 pandemic. So TBIs impose a substantial burden on the U.S. healthcare system, with about 1.5 million annual cases of TBI per year in the U.S., and up to 25% of them necessitating hospitalizations. Since 2020, the U.S. healthcare system has also been navigating the complexities of the COVID-19 pandemic, and especially at New York City Health and Hospitals Elmhurst, which was colloquially labeled the epicenter of the COVID-19 pandemic, as it was at the leading front of an acute surge of cases during the first wave of COVID-19, and necessitated public health countermeasures and a lockdown in 2020 in New York City to help mitigate this crisis. So both the COVID-19 pandemic, the lockdown, has altered the TBI patterns of TBI cases across the city, and also influenced the allocation of healthcare resources and TBI management. And thus our study was investigating this impact of the COVID-19 pandemic and resource allocation on the incidence, severity, and outcomes of TBI cases, as well as determining any disparities in TBI outcomes across socio-demographic groups. We also aim to help inform neurotrauma management strategies in the face of future public health emergencies. So we conducted an analysis of prospectively maintained institutional TBI database. We divided our cohort into pre-pandemic, first wave, and second wave to determine changes across different phases of COVID-19 pandemic.
and conducted a binary logistic regression analysis that, consistent with existing literature, dichotomized outcome based on discharge destination, with good outcome being discharge to home and acute rehab versus poor outcome being skilled nursing facility, subacute rehab, hospice, and inpatient and hospital mortality. We also conducted an analysis comparing weekly TBI admissions with COVID cases / infection rates across New York City. So 443 patients met our inclusion criteria with a median age of 56. The weekly admission rate was 5.6 patients per week, TBI patients. Group 2, which was the first wave of the COVID-19 pandemic, had significantly lower weekly admissions compared to Group 1, pre-COVID and post-COVID. Over the course of the pandemic, we found that the proportion of uninsured patients decreased from 15% to 4%, and patients on public health insurance, Medicaid, and Medicare coverage rose from 25 to 41% and 20 to 28%, respectively. Here, we compare the total TBI admissions per week at New York City Health and Hospitals, and also the COVID-19 pandemic new cases in New York City. And we noticed that at the start of the lockdown, there was a significant decrease in TBI admissions that has returned to post-pandemic rates as starting 2021. On binary logistic regression, we found that increased age, injury severity score were inversely correlated with good outcome, and GCS score was positively correlated as expected. Of note, we did find that patients self-identifying as Black / Hispanic ethnicity and public health insurance patients having Medicaid and Medicare coverage were both associated with less favorable outcomes in terms of discharge. Group designation, sex, COVID-19 status, and a need for surgical intervention were not correlated with any changes in outcomes. So in conclusion, despite changes in TBI admission patterns across New York City and over the COVID-19 pandemic, there was a consistent quality of patient outcomes at our institution, which was assessed by discharge disposition in this study. However, two important socioeconomic factors such as ethnicity and health insurance status were significantly associated with outcome, underscoring potential ongoing sociodemographic and socioeconomic disparities in healthcare. We do acknowledge a confounding and a plausible explanation for this disparity, which is most patients that have public health insurance, which according to literature tend to be from minority backgrounds, could also face differential access problems or obstacles, especially when it comes to acute rehabilitation after hospital care. But overall, our study captures a snapshot of TBI admissions at the epicenter of the COVID-19 pandemic, revealing a significant decrease in TBI admissions during COVID-19, which returned to pre-COVID numbers and ranges recently, without a significant reduction in the quality of healthcare delivered to these patients, given the strain that was placed by the COVID-19 pandemic and the reallocation of resources. Thank you very much.
Thank you, Bahi. Any questions or comments? Nice job. Next up, we have Dr. Matt Carr, who's mentored by Dr. Reed.
Good morning. My name is Matt. I'm one of the PGY4 neurosurgery residents here. I'm also a graduate of the Virginia Commonwealth University School of Medicine as well. Go Rams. I'll be presenting here on some recent data on a large health system-wide database of spinal metastases. This has been a team effort creating this database, as you can see here, but it's led by Dr. Reed in our department and then Dr. Doshi in the radiology department. We have no relevant disclosures. As I'm sure many of you are aware, the spine is obviously a very common location for cancer metastasis, something we're commonly consulted on as neurosurgeons. And these metastases can be quite debilitating. They can cause pain, they cause neurological deficits, or even paralysis. And so recognizing and treating these metastases as they arise is critically important. And as cancer treatments are getting better, we're getting better at controlling both systemic and local tumors, and hopefully preventing neurological deficits and pain and improving quality of life in these patients. However, factors regarding the diagnosis and management of these spinal metastases, particularly related to social determinants of health, remain understudied. So the objective of this study was primarily to categorize whether the location of the initial spinal imaging affected the time from diagnosis to management of spinal metastasis. And then secondarily, we wanted to look at whether the location of the spinal imaging affected what the initial treatment modality was for these spine mets. We did this first by creating a database by querying the radiology reports from within the health system for any terms indicating possible spinal metastasis from 2017 through 2021. And then we had this great chart review from Epic collecting relevant clinical and demographic and treatment variables for these patients. We stratified imaging setting as emergency, as in the emergency department, inpatient or outpatient, and the treatment modalities that we looked at were chemotherapy, radiation therapy, or surgery. The time to treatment was then the days between whenever their initial radiographic imaging showing a spine met and the initial treatment of that spine met. And we set P less than 0.05 for significance. So our query of the database returned 1,728 patients with possible spine mets, and then once we combed through the data, we were left with 1,043 patients, about 60% of those who had full records of treatment of actual spine mets. And here in table 1 is just the sort of overall demographics of our sample. About 10% of these patients were diagnosed in the emergency department, 30% as an inpatient, and 40% in an outpatient setting, with the remaining 20 having no known setting of their imaging. The average age of patients was 64 years old, and it was a pretty even split between males and females, with a very slight female predominance. The mean time to treatment overall in this sample was just about 40 days, 39 days. And the time to treatment was shortest in the inpatient setting at 28 days, then the emergency department 33 days, and the outpatient setting 48 days. And the difference in these 3 settings in this average time to treatment was statistically significant. And then looking at the initial treatment modality for each of these settings, we found that it also significantly changed depending on where you were diagnosed, with those diagnosed in the emergency department being more likely to receive radiation or surgery initially, and those being diagnosed as outpatients most likely to receive chemotherapy, and those inpatients are sort of in between, which is all rational. We did a brief sort of sub-analysis of these, and as expected, those diagnosed in the emergency department typically were having emergency surgery or emergency radiation. When we looked at those who had treatment within 7 days of diagnosis, about half of those patients who had surgery in the emergency department, for example, were diagnosed or treated within a week of diagnosis. So in conclusion, time to treatment is shortest in those diagnosed as inpatients and longest in those diagnosed as outpatients, which is somewhat intuitive. And then those who are diagnosed in the emergency department are more likely to have surgery or radiation as their initial treatment, and outpatients are more likely to have chemotherapeutics as their initial treatment. Thank you all for your time. I'll take any questions.
Do we have any questions for Dr. Carr? Okay, thank you, Matt. Next up, we have Ryan Afreen, who is mentored by Dr. Kellner.
Hey, Ryan, you're muted. You're muted there.
We're not hearing you.
Sorry, can everyone hear me now?
Yes.
There you go. Go ahead.
Go ahead and just start over.
Yes. Hi, everyone. I apologize for the inconvenience. My name is Ryan Afreen, and I'm a first-year medical student at Sinai. And today I'll be talking about the effect of COVID-19 pandemic on the clinical outcomes of inter-hospital transfer, specifically for intracerebral hemorrhage patients or ICH patients who underwent minimally invasive surgery. I have no conflicts to disclose, and other authors report no conflict of interest for this work. So intracerebral hemorrhage, or ICH as we know, accounts for 10 to 20% of all strokes, which means it's marked by a very high morbidity and mortality. However, minimally invasive surgery, or MIS, shows improvement in outcomes. Specifically, early or prompt treatment shows a functional benefit, as demonstrated by the ENRICH trial. However, what really lacks is, can MIS lead to improved outcomes in similar ways as thrombectomy for acute ischemic stroke, or will systems of care need to evolve to provide access to this breakthrough in ICH care? Additionally, there's also a huge lack of data on the safety and efficacy of inter-hospital transfer, or IHT, for ICH patients. So as we know, even before COVID-19, there are a lot of reasons why IHT can be associated with potential delays and worsening outcomes. However, what we don't know is how COVID-19...
Sorry, Peter, I'm not sure if we're seeing all the slides.
Yeah, they're not advancing.
They're not advancing, Ryan. Thanks.
Are you able to reshare?
Yes. Can everyone see them now?
Yeah.
You can. Yeah. Go ahead and advance and see if it works. Great. Okay.
Okay, awesome. I can restart from here in the intro.
Yeah, just that. Yeah, you can go to where you were in the talking. I think that's fine. Yeah.
Okay. So as I was mentioning before, that what we still don't know is how COVID-19 impacts IHT for ICH patients. Therefore, our objective was to assess the impact of a centralized triage and transfer system known as the NEMAT for ICH patients during different phases of the COVID-19 pandemic. We specifically looked at short-term and long-term outcomes that I'll be explaining more in the next slides. So we divided our COVID-19 timeline into 3 different phases, with the first phase being the pre-pandemic, which was before February of 2020. The second phase was the first wave of COVID-19, which ranged from March to December of 2020. And the third phase was the second COVID-19 wave, which was after January of 2021. We also divided our study cohort into 2 groups, with the first group being patients who were directly admitted via ED, and the second group were the inter-hospital transfer patients. And the 4 primary outcomes that were measured, with the short outcomes being symptomatic post-operative rebleed and suboptimal discharge disposition, and the long outcomes being the 30-day mortality and poor functional outcomes. So we had a total cohort of 261 patients, and 40 of those patients were directly admitted and 212 patients were transferred. Evaluating the demographic characteristics, ethnicity, insurance, age, race, sex, and even COVID-19 phase were not different between these 2 groups. Comparing the additional disease-specific characteristics, including medication views or whether patients receive platelets or not, or even presenting clinical characteristics, NIH stroke scale were not different, except for the GCS score, which was lower for transfer patients. Also specifically evaluating outcomes between these 2 groups, the only outcome that was different was symptomatic post-operative rebleed, which was seen higher in transfer patients. While we looked at various factors, including transfer times, distances, day of the day, and borough that patients came from, I want to highlight the door in and door out time. It seems a little longer, 4.9 for our study, compared to the NEMAT time, which is usually 2.2 hours, because some of these patients are probably coming from centers that have different systems of care, or they may require more stabilization prior to the initiation of the transfer. So this is where we have some really interesting data for our outcomes. For the binary logistic regression model, for the first one, we saw that spot sign and evacuation percentage was associated with symptomatic post-operative rebleed. We also saw that for suboptimal discharge disposition, age, and ICU length of stay were statistically significant. We also evaluated that anticoagulant use significantly increased 30-day mortality, and age and deep ICH and ICU length of stay were statistically significant for poor functional outcome, which was measured through MRS. I also want to highlight that transfer was not a significant variable associated with poor outcomes for any of these models. Therefore, our study shows that IHT is safe for ICH patients, as it did not significantly impact the 4 primary outcomes that we measured. Therefore, overall, the study shows that a centralized triage and transfer system like the NEMAT system can actually adapt a systems of care approach to ICH triage and transfer, even during COVID-19. Therefore, safe and efficient IHT is definitely a promising strategy for innovative breakthroughs in ICH care. I'd like to thank my mentor, Dr. Rangayaj, Dr. Kellner, and the entire research team for helping with this project. And thank you for the entire neurosurgery research department for giving me this opportunity. Happy to take any questions.
Thank you, Ryan. Nice job. Do we have any questions?
If there are no questions, just a quick comment about both systems of care projects that Bahi presented and that Ryan presented. It shows that despite COVID-19, the quality of care did not suffer. So having a systems of care multidisciplinary approach can make a difference and potentially withstand the impact of a pandemic. Good job, Ryan. Thank you.
Thank you.
Thank you. Next, we have Brendan Philbrick, who is mentored by Dr. Shigematsu.
Okay. Let me swap these. Right. Does that look better?
Yes.
Okay. So I'm Brandon. I'm one of the PGY3 residents here. I'm going to be presenting my work of a pilot retrospective multi-center study with a new 7 French guide catheter that we've been testing out. Quickly starting with some background information about guide catheters. These are essential devices in cerebrovascular intervention cases. They serve as vehicles for contrast injection. It's a conduit for both wire and device transport to access the distal cerebral vasculature, and it also uses the mechanical properties of the catheter to support further device advancement into the cerebral vasculature. Most guide catheters have distinct points of transition in their mechanical properties, which limit their ability to actually advance more distal into the head and neck. And due to the relative rigidity and size of these catheters, we often have to use an intermediate catheter, which can then advance further before actually deploying microcatheters and devices for embolization procedures. Some of the pictures over here on the right side show commonly used guide catheters, where each change in the color of the catheter as it goes more distal represents a distinct transition point in the mechanical properties of that catheter. So for example, in this catheter, we have 4 different transition zones. One company called Radical has developed a new guide catheter that uses new types of technologies, which aims to have variable stiffness along the entire length of the device to allow for better flexibility and distal catheterization via improved steerability and trackability. This is a 7 French guide catheter that can be used for both femoral and radial access. It uses a hybrid ribbon manufacturing technology, whereas in the picture over here, each different color is a different ribbon with a distinct mechanical property, and then adjusting how these ribbons are interwoven and the design allows for a much more gradual change in the mechanical properties of that catheter as it goes more towards the tip of the catheter. This device received FDA clearance in November of last year. In our study, we did a first-in-human study both here at Mount Sinai and at the Cleveland Clinic. We had 8 different operators, and we analyzed the first 30 consecutive cases in adults that use this catheter between 1 month after it received FDA approval through February of this year. We looked at the patient characteristics, the procedures of the procedures, vascular lesions, and adverse events. Going over the characteristics, we did 80% of the cases were elective, with 20% being emergent cases. Or half of the cases were for aneurysm embolizations. These are both ruptured and non-ruptured cases. We did 5 MMA embos, some AVM embos, thrombectomies, and then a few different other myriad of cases at the bottom. We did both radial, femoral, arterial, and venous access using this catheter. We were pleased to report that there were 0 device-related adverse events. 4 patients did have serious adverse events, but none of them were felt to be related due to the catheter selection in this case. Excitingly, in 16 cases where an intermediate catheter would have been used, we were able to omit the use of an intermediate catheter in 15 of these cases, and we were able to get to the target vessel in 100% of the cases. I just wanted to highlight a couple case examples of how this catheter works and some of the new features that we see. This is demonstrating the catheter very easily navigating through the carotid siphon and going all the way up to the ICA terminus, which is usually not something that's able to be done in most guide catheters. This next example shows a posterior circulation case for a ruptured aneurysm where the guide catheter was able to advance all the way through the V3 loop without any difficulty or any significant distortion of the parent vessel. Right. This is a side-by-side from the same case where we had two different guide catheters, one on the right, one on the left vertebral artery, and then these red arrows show that on the patient's left is the new radical catheter compared to a benchmark catheter, which is very commonly used. And you can see how much farther distal this catheter was able to go compared to the benchmark. And then in this final case, this is for extracranial circulation. This is the catheter advancing all the way to the origin of the IMAX for an MMA EMBO case, which is more distal than most guide catheters are typically able to go. And then from here, we are able to easily deploy the microcatheters and microwires for access to the MMA for the embolization.
30 seconds.
All right. In conclusion, these catheters using new ribbon technologies for manufacturing have been shown to be safe catheters for both arterial, venous, femoral, and radial access. These catheters offer several benefits of distal catheterization without an unsafe degree of vessel distortion, which is an advancement in the technology, a large advancement of the technology compared to the most commonly used guide catheters on the market right now. And then these may allow for interventional cases without the use of intermediate catheters. And just to highlight that these intermediate catheters can sometimes cost thousands of dollars, so it may actually be saving quite a bit in the total supply cost for a case. With that, I'll end my talk here. I'd like to thank Dr. Shigematsu, Dr. Kellner, and Mark Bain over at the Cleveland Clinic for helping out with this study, and I'll take any questions.
Thank you. Do you have any questions or comments? Dr. Richardson?
Nice job. You know, as someone who had virtually no exposure to endovascular neurosurgery in residency, and obviously none since, in kind of watching this field, it seems like there's always a new device. Can you help me understand, you know, what kind of jump this is from the existing technology? Is this something that's like a big increment, or this is like order of magnitude? How different is this than the existing technology?
Yeah, I think that this is having a catheter that's this versatile, and we're able to bring it so much further distal. It's going to really kind of shape what interventional catheter selection and device selection is going to be going forward when they're actually trying to access these lesions. So it's providing a much more stable and faster way to access lesions that are more distal in the cerebral vasculature without having to employ additional devices to actually get to the target.
Exactly. Thank you, Brian. I just want to add one question, if you can hear. Yeah, this guiding catheter is not well highlighted in the endovascular world, maybe, but if you think from the neurosurgical standpoint, placing a guiding catheter is a craniotomy, and then using the intermediate catheter is opening a sylvian fissure. And if we just use this device just once and it goes up high enough, to get the aneurysm, the guiding catheter, or this catheter is already there. We did the craniotomy, and then the opening the sylvian fissure is one step. And the aneurysm right there, we just need to treat the aneurysm. So the technology is kicking into the endovascular world quietly, but it's a big movement, and we're very happy to test this device first. And yeah, great job, Brian.
All right, thank you. So we'll move on to Jack Zanning, who's mentored by Dr. Zoe.
Good morning, everybody. I'm Jack. I'm a scholarly year student applying to neurosurgery this fall. Today, I'm presenting some of the highlights from our ongoing project on glioblastoma and plexin D1. So while there are many facets of GBM that we can go into that contribute to its malignancy, today we're going to mainly focus on what drives its invasion, which is our interest in the lab. So a key principle at play is membrane tension. So brain tissue is very dense, and as these cells are squeezing through all these tight extracellular spaces, they endure all kinds of tremendous forces like the ones depicted here. As such, membrane tension is very critical for a lot of things, including preserving cell structural integrity, but also avoiding immune detection. But even just beyond mere survival, a scientist in the lab, Christian, recently showed that membrane tension actually plays a key role in cell movement as well, which we'll return to later on. And as cancers tend to co-opt developmental pathways, development is a really good place for us to start when we want to investigate these things. So with that, plexins are a protein of interest. They play really key roles in development. They're guidance molecules. And in particular, plexin D1 is a member of this class, and it's upregulated in higher grade gliomas. So it's a very interesting target for us. For the sake of time, a lot of work has gone into this, a lot of really interesting, incredible in vitro work before I got to the lab. So I'll just rapid fire through that, but happy for any questions. So Sanjo in the lab, a postdoc using CRISPR, knocked out plexin D1 in this glioma stem cell line called ST3. And here's just a Western blot showing that the protein expression is down. And these are the cells we're using moving forward. And then Christian and Christy use these specially engineered microchannels to model the confined migration of tumor cells through these tight spaces. And essentially, they observe very interesting phenotypes between the control and the KO cells. Just to summarize all the quantifications here, knockout plexin D1 seems to result in decreased membrane tension, which manifests with reduced movement, reduced distance, but interestingly, also the formation of these tethers that are kind of pulling these cells together, as you see in this picture. And I think we kind of appreciate this a little bit better in some culture pictures here, where you see these tethers and a quantification comparing knockout to controls. Now, for my part of the project, we want to study how these cells behave in the brain in vivo. So I perform intracranial transplantation of the tumor cells into the brains of these mice, sacrifice them, perfuse them, section them coronally. Here's a representative image with the tumor cells stained red. As you can see, a large bulk forms reaction site, and here's the direction of invasion across the corpus callosum. So now if we want to examine control versus knockout more deeply, we see a very striking difference in how far the tumor cells invade to the contralateral side between knockouts on this side, where they barely cross midline, quantification here, as well as the control, where they're seeding really effectively. And here on this slide, if we look at the contralateral corpus callosum, we can get a better picture of just how effective the control cells are, where they're seeding upwards into the cortex, as well as downwards into the striatum, as opposed to the knockout, which very few cells really make it across. Now, if we look down to a different area in this tumor bulk area, we see that on the bulk margins and the controls, there's a highly invasive, very aggressive tumor front that's pushing out from the bulk towards the edge of the section, right? But in the knockouts, this is just not the case. The invasion front is almost completely absent, minus a few cells. The cells are all kind of clumping together as this massive bulk. And we think that this is a manifestation of the changes in membrane tension, motility, and tethering that we observed in culture. So if we go back to the corpus callosum, here we're staining with NCAM, so tumor cells are green. We can first appreciate what the tumor cells look like during confined migration. We see how they're being squeezed. Even their nuclei are fusiform and elongated under all those intense pressures that we were talking about. But the knockout cells, this is still preliminary, so we're analyzing it, but it seems like they're actually longer. They're being squeezed even more, likely due to softer, more pliable cell membrane. It also seems like the membrane cells have these long tethers that we observed in culture as well. Moving on to slightly off to the midline of the callosum, we can appreciate how nicely elongated these cells are as they're invading across. We can also see that they're kind of aligned in the direction of migration. It's like a streamlined force that's moving over. Whereas for the plexin knockout, we see that there's just the tumor cells are completely disorganized. They're crisscrossing each other. They don't really know which direction they're supposed to be going. And there's a lot of evidence growing in the field that plexins act independently as mechanoreceptors. So it could be that loss of plexin results in loss of this mechanical sensing capability, and there's just migration is disorganized. So final data point here, we turn to callosum one more time. If we blow up this image, this is just showing that it looks like the tumor cells are in red now, and the immune cells are labeled in green. It seems like the tumor cells with the plexin knockout condition are immunogenic. They're attracting more immune cells. And our working hypothesis is that because they don't have membrane tension, they can't extract the processes that they're extruding. And so they're basically shedding and leaving a trail that is bringing the immune cells onto their case. So here's a quantification. Looks like it's about 2 times. So these are our conclusions. Loss of plexin D1 associated with reduced invasion, increased tethering, disorganized migration, and increased immunogenicity, potentially due to shedding. So with that, I'd like to thank everybody for the attention, department for the opportunity, and my mentors and lab for a wonderful year. And I'll take any questions with the remaining time I have.
Thank you, Jack. Does anyone have any questions?
Thanks again.
I just have one for you, Jack. These are I feel like, and this isn't intended to be discouraging, but, glioblastoma is a really tough disease to study. And I feel like we do lots of knockout studies or drug targeting studies, and it seems like it never really moves the needle.
Right.
Is there something about this that you feel like is different from prior attempts to sort of characterize ways of controlling glioblastoma in terms of looking at migration or other areas that might be more successful?
Yeah, it's always hard to say. Everything always looks promising in mice, and then we transfer it over and spend a bunch of money, and it doesn't go anywhere. So I definitely see that frustration. I think what's interesting here is that this is kind of studying one, I guess, if we were to extrapolate potentially optimistically, it's kind of nice that knocking out of this protein results in a large bulk formation. It kind of I think something that Dr. Zhou and I have been talking about a lot is kind of a new frontier in understanding how glioblastoma works in terms of shift from invasive growth to expansile growth. Like there are different growth modes that we really haven't probed deeply before. And I think, whether or not Plexin actually becomes therapeutic, I think it's interesting to consider that a growth mode can be changed. And so if we were somehow to kind of shift it towards a preferentially expansile growth mode where it goes as a bulk, that could kind of have implications for like, maximum extent of resection and things like that. But it's still very preliminary data, and it's always really hard to say if it will actually go anywhere. So
it's a great point. What you see on MRI is not the whole disease in glioblastoma. And so if you could make an impact on that, that could be helpful.
Right. And we're also looking at the margins as well. And there's a lot of interesting good things going on there in terms of tumor microenvironment, role of myeloid cells, T cells, and things like that. So it's a burgeoning field for basic science as well.
All right. Well, I want to thank all of our long format research presenters this morning. We're just going to take a quick 5-minute break before we go to the rapid fire posters, everyone to sort of arrange themselves and make sure you're comfortable. The rest of the presenters, just a reminder, these will be 2-minute rapid fire abstracts. So when we start up with those, that's what we'll have for the remaining presentations. And lastly, just a reminder to everyone who's still on, at the end of the rapid fire abstracts, we'll present the award winners. So please remember to stay on for that. So we'll be back on in 5 minutes to get started. Okay, everyone, let's go ahead and get started. Once again, these are 2-minute rapid fire poster abstracts, and we're going to start with Tyrone Young, who's mentored by Dr. Betterson.
Good morning, everyone. I'm Tyrone Young. I'm a second-year medical student here at Mount Sinai. Today, I'll be discussing our qualitative review of navigated microscope integration and heads-up display at our institution. So HUD is an augmented reality system that projects anatomical structures directly into the surgeon's microscope view, allowing for full focus on the surgical field while simultaneously visualizing the relationships between critical structures in real time. On the right, I have a picture demonstrating heads-up display overlaid on the brain surface after opening the dura. And so what you're looking at are projections of the optic nerve in yellow and the tumor in purple, which help to quickly identify the plane of initial dissection around the capsule of that tumor in purple. The solid lines indicate the boundaries of the structure at the current focal depth of the microscope, and then the dotted lines indicate the maximal boundaries of the structure in the plane of the microscope view. So we conducted a retrospective review following strobe guidelines of all patients from April 2016 to March of 2023. So HUD was utilized in 440 surgeries, accounting for almost 32% of all surgeries performed by the same attending surgeon over this 7 years. Looking at our graphs on the right, so the cohort included a wide range of pathologies categorized into meningioma, vascular conditions, extraaxial, excluding meningioma, and intraaxial. Primary surgical approaches included convexity, retrosigmoid, pterional, and suboccipital. Lesions were located in diverse regions, most commonly posterior fossa, non-skull-based supratentorial, anterior fossa, middle fossa in the sellar and parasellar regions. And then on average, each surgery involved the segmentation of about 3.14 structures, most commonly lesions, arteries, cranial nerves, and veins and sinuses. And then over time, we observed an increase in the frequency of HUD use as well as the diversity in these respective categories. In conclusion, our experience underscores the significant role of HUD in advancing neurosurgical techniques, confirming its effectiveness in enhancing surgical precision and efficiency. Pending any questions, that concludes my time.
Tyrone, do you have any questions? I think this is a really interesting technique that the residents recognize that is frequently used here, but I don't think is broadly used. I'm interested in whether you've considered broadening this to more surgeons who use this and possibly doing a multi-center analysis of how this can be useful compared to non-use of the technology. And in addition, as a second part to that, whether there is a learning curve effect of using this technology.
Yes, sir. I think, I guess on the first part of that, this project was specifically just a review of what's been done. And in the future with Dr. Feng and Dr. Betterson, we're hoping to do more of a quantitative analysis of initially our single center experience, and I think expanding would be definitely a great idea. And then for the second part of that, the application of this HUD with just this interface with just Dr. Betterson over time, I think definitely demonstrates with him and as well as the staff that there's probably a learning curve involved in terms of the frequency of use.
Okay. Next up is, sorry, lost my page. Sheena Caligara, who's mentored by Dr. Kell.
Thank you. Hello, everyone. My name is Sheena Caligara. I'm a medical student, and my mentor for this project was Dr. Kellner. So cerebral amyloid angiopathy is a major cause of lobar intracranial hemorrhage, and it's important to identify the patients with this underlying etiology as it's associated with worse surgical outcomes and higher recurrent rates of hemorrhage. So the Boston criteria were initially released to help evaluate the likelihood of CAA etiology based upon clinical and MRI features, and they've been updated 2 times since, with the release of version 1.5 and more recently 2.0 in 2022. Importantly, there are 2 classifications that can be noted with the Boston criteria: probable CAA, which generally requires the presence of at least 2 MRI features, and possible CAA, which requires the presence of 1 MRI feature. While initial analyses into the diagnostic accuracy of these guidelines were performed by the team that released these guidelines on their cohort of patients who presented with spontaneous ICH and other syndromes associated with sporadic CAA, It's important to validate these criteria in a variety of clinical presentations, such as those patients undergoing surgical treatment. So here we aim to validate the Boston Criteria version 2.0 for patients here at Sinai who underwent minimally invasive surgical evacuation of ICH. So in this study, we collected MRIs and brain biopsy samples from 186 included patients. Histological analyses for CAA were performed, and 2 blinded reviewers assessed MRIs for imaging biomarkers for both the 1.5 and 2.0 criteria. So the analyses revealed greater diagnostic capabilities of 2.0 for all variables in probable CAA and a trend towards its impossible CAA. Upon evaluation of the accuracy of these guidelines, the observed accuracy of 2.0 was significantly better than the no information rate, signifying the fidelity of this set of metrics and highlighting that this finding was not seen in version 1.5. This highlights the improvements of the set of guidelines and the potential implications for future clinical practice. Thank you.
Thank you, Sheena. Any comments or questions? Okay, next up is Preeti Reddy, who is mentored by Dr. Majidi. No problem.
Hi, I'm Preeti, and I am a medical student doing my research here with Dr. Majidi. I'm going to be talking about subarachnoid hemorrhage during pregnancy. So although it's pretty rare, subarachnoid hemorrhage during pregnancy is the cause about 4.1% of all pregnancy-related deaths, so it has a very high mortality rate. And overall, because it's so rare, a lot of studies don't have a large sample size, which is why we looked at the National Inpatient Sample Database. We specifically selected for pregnant patients between the years 2000 to 2019, and we separated into 2 cohorts, the pregnant cohort and the non-pregnant cohort. We excluded AV malformation, cerebral arteritis, had trauma and traumatic hemorrhage. We did 1-to-1 propensity matching, and then we did a multivariable analysis using that. And we also analyzed trends over time. Overall, we saw that the number of pregnant patients who developed subarachnoid hemorrhage increased over this 20-year time span. However, the proportion of overall subarachnoid hemorrhage patients who are pregnant stayed around the same. So that indicates a change in diagnostics and better diagnostics over time. We noticed some healthcare disparities. For example, African-American patients and those on Medicaid insurance were more likely to be pregnant patients with subarachnoid hemorrhage. And we also noticed that pregnant patients overall had fewer comorbidities, and they had fewer rates of hydrocephalus, coma, ventilator use, and were less likely to experience aneurysmal subarachnoid hemorrhage, which tends to have worse outcomes. We also noticed pregnant patients experience seizures more often, and overall in-hospital outcomes were better for pregnant patients, including in-hospital mortality. And after propensity matching, we had similar results as before in terms of in-hospital outcomes. So in conclusion, although subarachnoid hemorrhage in pregnancy is rare, subarachnoid hemorrhage in pregnancy is less morbid in pregnant patients compared to the general population. And I'll take any questions.
Thank you. Does anyone have any questions? Okay. Next up is Chi Lei, who is mentored by Dr. Cutler.
Good morning. My name is Chi. I'm one of the second-year neurosurgery residents. And today I'll be presenting on behalf of my team an extension of the work that Ian has presented earlier on the performance of AI-powered evaluation of midline shift in patients with intracerebral hemorrhage. So we know that AI can be leveraged for timely evaluation of ICH, and it has potential to help us identify early on neurosurgical candidates. So our study was looking at a retrospective cohort of 72 ICH patients that presented to our institution between 2015 and 2021. Our cohort has an average age of around 66 years old. 60% of them were men. The mean initial ICH score on arrival was 2, and the median NIH stroke scale was 15. Based on the available CT head imaging of the 72 patients, we had a human review the imaging, and then the data was also fed into the WITS AI ICH algorithm, which as its core is a convolutional neural network. So in comparison to the human reviewer, the algorithm was able to detect midline shift with 94.7% sensitivity and 77.4% specificity. The positive predictive value was 60%, and the negative predictive value was 97.6%. Beyond just detection, we were also interested in the actual measurements of midline shift, and we found that the average absolute error between the AI as well as human was 1.3 millimeter. And we also looked at a Spearman correlation between the human and AI measurements. We found it to be 0.81. In context, 1 is a perfect correlation, and we found this to be statistically significant with a p-value of less than 0.001. So I think our study demonstrated the promising performance of AI algorithm in midline shift detections in ICH patients with high sensitivity and negative predictive value. And we think that this is laying the groundwork for hopefully even future work, looking at how AI-powered technology can help facilitate timely triage of ICH patients and then ultimately impact patient care. I want to thank my team and Dr. Kellner for his mentorship, and I'm happy to answer any questions.
Yeah.
Thanks, Chi. Is this available for clinical use right now for our ICH triage, or just in the research realm right now?
My understanding is that it's mostly for research for right now. I don't know if Dr. Kellner could comment more, but my understanding is only for research at this time.
Thanks.
We'll move on to Emily Chapman, who's mentored by Dr. Majidi.
Hi, everybody. So my name is Emily Chapman. I'm one of the PGY2 residents. Okay, great. Okay, so yes, I've been working under Dr. Majidi, and today I'm going to talk about a research that we've done on acute ischemic stroke using a very large national sample, specifically those with CNS infections. CNS infections are thankfully quite rare in this population. That encompasses encephalitis, meningitis, brain abscess, but just anecdotally, we've seen that the impact can be pretty catastrophic. And so we wanted to better characterize this population and their outcomes. We used the national inpatient sample, which is spanning over 20 years. And we looked at clinical outcomes, including ultimate discharge disposition, which I'll get into in a little bit. But first of all, the methodologies over these 20 years, we called ischemic stroke patients using ICD diagnosis codes, and we then performed a univariate analysis with t-test and chi-square. We used one-to-one nearest neighbor matching to generate propensity scores to create optimal populations for comparison. And we use an alpha level of for significance less than 0.01 using our program software. Want to also take a second to thank Trevor for writing up and running this code as part of this analysis. Looking at our results now, you can see that ischemic stroke patients, there's a very large population, about 10.5 million, and of this low percentage, 0.7%, actually had these CNS infections. So thankfully, we had this large sample to help power our analysis. These infected patients did start off with higher comorbidities overall, as well as higher NIH stroke scores, and did have unsurprisingly higher rates of systemic inflammatory disease, as well as rates of going to the OR for drainage. Overall, these patients did have longer hospital stays, cost the hospital more per patient, and also were more likely to go to facilities and otherwise not be discharged home. So these patients overall did have higher comorbidities, higher NIHS scores, and had worse functional outcomes. I think we do need to better understand these hospital courses to see how we can best treat these patients as they're during their admission and also after discharge. Thanks so much.
Dan, you had a question?
Yeah, I'm just curious why you think that there's like such a dramatic increase in the number of infections. Is it because like more people are getting TPA or TNK, we're doing thrombectomy, more people are hemorrhaging, EVD, hemicranie, like it's just that we're intervening more and causing infection, or what's going on
Yeah.
there?
That's a great question. So you'll see from the line graph here that both the absolute number and the rate, the overall proportion is increasing over the years. Yeah, and I think that's a good hypothesis. Again, I would have to sort of analyze further the patients that do end up with these infections. How is their postoperative infectious profile in particular? And like you said, with these, we're saving more patients, we're intervening more. That's great, but also that means that they are going to have a more complicated post-op course, most likely. Maybe they get a pneumonia because they're much more likely to be ventilated. And as a result, there may be a higher correlation with these CNS infections. So definitely, particularly as these numbers go up, something interesting and important to investigate. Okay.
Thank you. Next up, we have Jeff Simmering, who's mentored by Dr. Mako.
Hi, my name is Jeff Simmering, and I'm a PGY7 chief resident. Pain management is an important issue in cancer palliative care. 30 to 40% of cancer patients suffer with intractable pain. Intrathecal drug delivery via surgically implanted pump is an emerging treatment option. Here we conducted a retrospective review of 193 cancer patients treated with intrathecal pain pumps at MSK Cancer Center between 2013 and 2021. The surgical procedure involves placing the patient in the lateral decubitous position for sterile draping of both the lumbar spine for CSF access via lumbar puncture with a 16-gauge TUI needle and the abdomen to hold the pump reservoir. Once CSF egress is confirmed, the intrathecal pump catheter is then fluoroscopically guided to the desired spinal level based on the patient's pain syndrome. For example, epigastric abdominal pain from pancreatic cancer has a catheter tip at T3, T6, T7, whereas axillary and or chest wall pain from breast cancer has the catheter tip terminating at T3, T4. The catheter is then tunneled subcutaneously to the abdominal pocket and connected to the pump. So the baseline clinical characteristics of the study is shown in the table. The median age was 59, and the mean time from cancer diagnosis to pump placement was 5.5 years. As shown in the table and figure, after average follow-up time of 10 months, there was a highly statistically significant reduction in median pain from 7 before pain pump placement to 3 after pump placement. 95% of the patients experienced a reduction in pain, and 53% of patients went from severe pain to mild pain. The average dose of morphine was 2.5 milligrams per day, and the average dose of hydromorphone was 3.5 milligrams per day. Median survival after pump placement was 3.62 months, and 11.3% of patients survived for 3 years, as shown in the Kaplan-Meier survival curve. The 1-year cumulative incidence of complications was 15.6%, and the 1-year cumulative incidence of re-op was 4.2%. Limitations of the study are its retrospective design and lack of a control group. And apart from the NRS, there really was no other measure of change in quality of life after pump placement. So in summary, pump placement for treatment of cancer refractory pain was a safe and effective method of pain palliation, and intrathecal delivery allows for use of lower doses of opioids, having fewer systemic side effects. The short overall survival following pain pump placement may indicate to us that earlier pump placement could result in improved quality of life in a larger proportion of cancer patients. Thanks.
Thank you, Jeff. Do you have any questions or comments? Jeff, have they done any studies on, you were mentioning catheter tip placement for different types of pain. Are there studies to show that that tip location is particularly important for each of the different types of pain, or?
Yeah, so it's kind of topographically mapped based on where would be the closest distance of drug diffusion across, to the dorsal horn of the spinal cord at that level. So, you know, if you're looking at the chest wall, the breast nipple, you're looking at T3, T4. And if you can start diffusing your morphine, you know, into the CSF space and across the gray matter, since it's a hydrophilic compound, into the spinal cord at that level, you're going to get a much higher effect than if you were, say, to just put the catheter tip at, you know, L1, L2 and, you know, leave it there. You're not going to get as potent of an analgesic effect because there's a further time for diffusion and bulk flow of that drug.
Has that been demonstrated?
Yeah.
Okay. All right, thank you. Next, we'll go to Halima Tabani, who is mentored by Dr. Majidi.
Good morning, everyone. My name is Halima. I'm one of the PGY4 residents, and today I'm going to be talking about the safety and efficacy of using a short 8-French sheet for transradial neurointerventional procedures. Over the last several years, transradial approach has been becoming increasingly commonly used and has been shown to have a significantly lower rate of access site complications, particularly in patients who are on dual antiplatelets and anticoagulation, as many of our patients are. However, there is limited data on the safety of using an 8-French sheet in the radial artery, which allows for stable access and support to target vasculature during neurointervention, such as accommodating multiple microcatheters, which are used during procedures such as complex aneurysm or AVM treatments. So our aim was to describe the technique and evaluate the safety and feasibility of using an 8-French sheet in the radial artery for neurointerventional procedures. The technique that we used was to perform a single wall ultrasound guided puncture of the radial artery, followed by insertion of a 5-6 slender sheet. Then we injected a spasmolytic anticoagulant cocktail and then swapped the 5-6 slender sheet for an 8-French sheet or a guide wire. We performed a retrospective review of a total of 122 patients who presented between January 2019 and March 2024. And of note, 92% of our cases or patients were undergoing complex interventions such as AVM and aneurysm embolizations, stenting, or stroke interventions. We achieved technical success in about 81% of the procedures, and the most common reasons for crossing over to transfemoral approach were difficult arch anatomy, presence of a radial artery loop, or spasm. Of note, we only had one immediate adverse effect, which was radial artery extravasation, and we didn't have any 30-day adverse events. On follow-up angiogram, about 83% of our patients had patent radial artery. So to conclude, this is the largest case series yet, showing the safety and efficacy of using an 8-French sheath in the radial artery with low complication rate and high success rate. Thank you very much, and I'll be happy to answer any questions.
I have a question, Halima. Is it normal to have, I calculate 17% occlusion rate of an excess artery at 30 days?
The mean follow-up time for a follow-up angiogram was about 7 months in this case, but in general, when we use larger bore guide sheets, it has been reported that it is common to have they have a higher rate of causing occlusion. So in this, I only mentioned that we had a fully patent artery in 83% of the patient. In about 15% of the patient, the artery was partially occluded, and we were able to open it up with a guide wire. And then in the rest of the cases, which is about 3%, it was fully occluded. So to answer your question, yes, as the bore of the catheter increases, it's more common to have more occlusive complications.
I think I would include that in an adverse outcome. Even if there's not a symptom, it's not what you're intending, I guess.
Mm-hmm. Definitely.
Nice work.
Thank you.
So next up, we have Ansley Unterberger, who's mentored by Dr. Shrivastava.
Can everyone see my screen?
Yes.
Great. So I'm Ansley. I'm a PGY1 neurosurgery resident here. Thanks for allowing me to talk about my research on the treatment characteristics for atypical meningiomas. So as we all know, meningiomas arise from the arachnoid mater and have the highest incidence of all primary CNS tumors. The World Health Organization categorizes them into 3 grades. Grade 1, benign, 2, atypical, and 3, malignant. Although 80% of meningiomas are benign, high grades like atypicals have increased recurrence rates of about 55% and portend poor survival outcomes. But because no standardized treatment paradigm exists for atypicals, there's been a push to explore various therapeutic modalities. So I've become particularly interested in investigating post-surgical adjuvant radiotherapy. To do so, I conducted an institutional series where I identified patients with primary atypical meningiomas who underwent either post-surgical adjuvant radiotherapy or surgery alone between February 2007 and March 2019. Using Kaplan-Meier methodology and log rate tests, I stratified outcome variables by treatment paradigm. And in doing so, I found that the tumor recurrence occurred 25% of the time in the surgery plus adjuvant radiotherapy group, compared to 42% of the time in surgery alone groups. Furthermore, median progression-free survival time was 22 months longer in the adjuvant radiotherapy group, and the 5-year progression-free survival rate was 31.4% higher in that same group when compared to surgery alone. So I just wanted to note that some might think that surgeons could inadvertently skew outcomes by preferentially treating subtotally resected lesions with adjuvant radiotherapy and forgoing similar treatment in the gross totally resected. But we performed Cox proportional hazard models, and they demonstrated that this wasn't the case. There was no significant difference per extent of resection or location. So in conclusion, this is a powerful approach to treat atypical meningiomas, which can affect survival outcomes significantly in this patient population. Future directions would be multi-institutional studies, as well as potentially analyzing genetic markers that might indicate recurrence rates or sensitivity to radiotherapy. Happy to take any questions at this time.
I'd agree with you that it's important to sort of pick apart the genetics of the different tumors, because that has a huge impact on these. And we see that in a number of other tumor types in terms of how that affects outcome in the context of their different treatments. Any other questions or comments?
I'll just comment that I think it's kind of cool that a PGY1 was already presenting research, a body of research before they've even, reached their PGY2 year. So kudos.
Thank you.
Right. On to our last abstract, Noah Nichols, mentored by Dr. Margettis.
Morning, everybody. I'm Noah. I'm one of the PGY3s in the program. I'm going to present an abstract today on neurological outcomes after a section of myxopapillary ependymomas. This is a single institution radiographic analysis. So as many of you know, myxopapillary ependymomas are rare lesions. They occur in the thecal sac within the lumbar spine. There are no formal guidelines for treatment, but standard of care is surgical resection with the aim of a gross total resection, because these lesions are intimately involved in the descending motor and sensory rootlets. Obviously, surgical intervention does come with a considerable risk profile. In this abstract, we tried to recontextualize that risk profile in the context of radiographic features of those tumors. So we reviewed consecutive cases of patients with histologically confirmed myxopapillary ependymoma at MSH from 2010 to 2021. We only included patients that had acceptable preoperative MRIs with and without contrast for radiographic feature measures. We identified 19 patients. There was only one patient that presented with isolated low back pain. Otherwise, the vast majority of them presented with some form of lumbar radiculopathy, most of them with pain syndromes going into the legs, some with motor weakness, several others with urodynamic dysfunction. We analyzed tumor volume. There was no difference in patients that had a stable neurologic exam compared to a worsened neurologic exam when you look at tumor volumes. there was also not a difference in the cohorts based on the number of levels affected. What we did see that was significant in terms of having a worse neurologic exam compared to the pre-op baseline was having a lesion that was associated with the conus as well as sacral involvement. There were 3 patients that had conus involvement. They all had poor exams after surgery. And also patients that had sacral involvement all had new or worsened urodynamic dysfunction after surgery. I thought that we followed these patients for a fairly decent amount of time, although the outcome could be improved. Average follow-up was 65 months. So in conclusion, when you're counseling patients on the risk of surgical intervention, really the thing to note is sacral involvement and conus involvement of those lesions. And also thanks to Colin Lamb for helping me out with this study as well.
Thank you, Noah. Do we have any other questions or comments? Yeah, I'm just going to take a minute to share my screen. So first off, I just want to thank our coordinators and program managers who helped organize this day. I did a very small amount of the organization compared to everything that they did. Sarah, Maggie, and I don't have on this slide, Sukaina and Jillian. This brain trust, so to speak, has really made this day go as smoothly as it possibly could. And you can tell from just the sheer volume of what we did today that it took a lot of organization. So all of these presentations were submitted, organized, graded by faculty graders, and then organized into today's agenda. So thank you to everyone who helped make that possible. We're going to move on with the awards presentations for today. The first is the Kalman Post Neurosurgery Resident Publication Award, which was endowed by Dr. Post's Family Foundation in 2007 and is intended to acknowledge and promote excellence in scholarship among our residents. And so this is selected by the faculty and awarded to what we consider to be the best peer-reviewed manuscript published or accepted for publication by a resident during this academic year, and is really a tribute to Dr. Post's impact on the department and on resident education and career development. So this year's Post Award winner, I'm happy to announce, is Dr. Schuper, who unfortunately isn't here today, but this is his for his study that was published in Journal of the American Heart Association as part of an ICH clinical trial on the impact of cigarette smoking as a risk factor for hematoma expansion in primary ICH. So congratulations to Alex. He'll be happy to hear about this when he gets back. And then on to our sneak preview, onto our Research Day runner-up and award winner. These were selected by Dr. Richardson based on all of today's presentations in the first group of the long-form presentations. There were many, many great presentations today, and I want to thank all the presenters. Dr. Richardson selected as our runner-up, our own Dr. Ray Feng for her presentation on computer vision in the ICU. So congratulations, Ray. And as the first place award winner, he selected Dan Cummins for his work on hippocampal and amygdala electrophysiology of human mind wandering and versus mindfulness meditation. So nice job, Dan, Ray, and all the presenters. I think this is really a tribute to how much high quality research is being done in the department, mentored by our faculty. Just want to thank everyone and of course, thank Dr. Richardson for being here and his focus during all the talks. Thank you.
Yeah, Peter, if you don't mind, I'd just like to say this was really, really impressive. This, it maybe exceeds the caliber of all the work I think our residents are doing at MGH. So that was a really, really tough decision. I think everyone that presented should be really proud of themselves because it's not easy to do research at the same time you're doing clinical neurosurgery. So really everyone that presented today is off to a great start, and it's just clearly a great environment to do this work. So keep it up, and thanks for the opportunity to see this.
I'd also like to thank a number of people. Mark, you really inspired us today. Your approach, your passion for what you do just came across in every word you said. I know that was really one of the best SachDev lectures that we've ever had. Also want to thank Peter for organizing this in a way that has never been organized before, acknowledging that you probably didn't do most of the work, and that we give many thanks to Sarah, Maggie, Jillian, and the others. But I'm glad you stopped sharing the screen, because if you look at who presented today and who's doing the work, it's medical students and residents. And that is so exciting. I just cannot tell you how pleased it makes me to see the young people coming up, deeply engaged in their own research, deeply engaged in mentorship. You could see who are the heavy hitters for mentorship. Obviously, you know, some of the attendings here are more involved and are mentoring multiple students. But this is maybe one of the most satisfying grand rounds and visiting professors we've had in a while to see what you all are doing. So thank you for that.
With that, I think we'll wrap up. So thank you again. Looking forward to another exciting research day next year.
All right. Thanks, everyone.